The webinar is now live.
Thank you very much, and hello. Welcome to the NHS Cheshire Governing Body meeting for June. My name is Andrew Wilson. I'm the chair of the governing body. I'm not going to ask colleagues to introduce themselves, but if when you speak, if people will just introduce themselves for members of the public that are in attendance, that will be helpful. This is, as always, a meeting which is held in public. It's not a public meeting, although we do have a section for public questions, which we do have some today. So we're not able to take questions directly on our discussions from members of the public, unfortunately, at present. Clearly, we're holding this meeting virtually because of reasons of COVID-19. And my opening remarks, I think, will be on COVID-19, the continual pandemic, which is still going on, and unfortunately, of course, as we all know, cases are increasing, and it's just a reflection that as a CCG we are dealing with that. We are dealing with the recovery of NHS services, which I think is of vital and importance to the population, that services are we catch up as quickly as possible and that all services are restored. So we're dealing with that. We're dealing, as we all know, with organisational change in the NHS. We continue to deliver and deal with business as usual. And the question we have from a member of the public is about the change of from one medication to another. And those things can be of vital importance to individuals. But so that's, that business as usual work needs to carry on going on as well. I'm just reflecting on all the things that are going on. And my thoughts were, if we were a private sector organisation, what would we be saying as a board? And we would probably be saying, this is too much stuff to be dealing with at one time. What's important and what we're going to deal with. I think our difficulty is that I don't think you can not deal with any of those things. I don't think it's within our gift to decide not to deal with any of those things. And so we have this dilemma that we need to deal with all of those things and we need to do them all well, but it presents some challenges. I think some of the things that we need to think through as we go on through today is how do we make sure that the ambitions we are setting are realistic and can be delivered, and that we can make a difference, because if we spread ourselves too thin, we will really struggle to do that. And I think that is something that probably will come out as we go through the rest of the meeting. Right, that's enough waffling from me. Right, we've done welcomes. Apologies. I have apologies from Neil Evans, Sinead Clark, Ian Ashworth and Matt Tyra. Christine, do we have any other apologies?
No, that was everyone.
Thank you very much. That takes us to declarations of interest. So in a second, I'll ask colleagues to declare any interests that either are not on their previously published declarations of interest or are particularly relevant to today's agenda. But I will say that, of course, there's an item on a GP prescribing incentive scheme where all GPs are clearly conflicted, and I will pass over the chair to Wendy Williams, our deputy chair, for that item to make a decision on what involvement, if any, there is of GPs in that discussion. But we do have a correct financial interest in that item, so we are clearly conflicted. I'm pausing to check if anybody wants to make an additional declaration. They don't. So that takes us to minutes of our previous meetings, which is the 20th of May and starts on page 3 of your pack. So if you go through page 3, page 4, page 5, page 6, page 7, page 8, page 9 and page 10. Are there any comments? Right, I've got Paula and then we've got Andy afterwards. So Paula.
Thanks, Andy. Apologies, my chat function wasn't working. Apologies. Just at the top of page 5, it talks about the High Sheriff of Cheshire being made an aware. I think it should say made an award to everyone involved. And then it also talks about yourself, Andy, as become chair of Cheshire and Merseyside. So I just think it's just a slight typo there. So.
Yes, I certainly have not become chair of Cheshire and Merseyside.
No, sorry, Cheshire and Merseyside CCG's Joint Commissioning Committee. That bit's correct. It's just that it says Dr. Wilson has become.
Has been become. Ah, yes, yes. has become. Yes. Okay, we can correct those. Thank you. Dr. McKelvey?
Thanks, Andy. There's quite a few typos, to be perfectly honest with you. Aware to award was one of them, and I sent them through some corrections to Christine last night. So I don't know whether I should go through with them now or go through it with Christine later, but there's a dozen or so little typos throughout the minutes.
If Christine has them and they're typos that don't change the meaning of anything, then I think we can deal with it outside of the meeting.
Correct.
Thank you. Any further corrections to the minutes? No. Thank you very much. So we're asked to approve those as a true reflection of our discussions, which I think we can do. It takes us to item 1.4, which is the matters arising or any actions. If there's anything anybody wishes to raise from those minutes, there are no actions. We've completed all our actions. I've never been in a governing body meeting where all the actions have been completed before, so it's quite nice. And nobody's putting their hand up to raise anything. So that takes us then to item 2.1, which is questions from members of the public. And we do have a question from a member of the public. So I will read that question out and we'll provide a written response. We may or may not have some comments for you now, but the question is received by Dan Feldman. NICE published new guidance on atrial fibrillation NG196 on the 27th of April, which includes the following recommendation. For people already established on a vitamin K antagonist, the committee agrees, that's warfarin and the like, for those who know, the committee agrees that the benefits of changing to a direct acting anticoagulant need to be discussed. Therefore, the risks and benefits of changing medication, the person's time in therapeutic range and the person's preference should be explored at the next routine appointment. And the questions are, does the CCG have a general process to ensure applicable NHS guidance is implemented? And can you give an assurance about the above will be carried out? I'll pause to see whether anybody wishes to comment on that now. If not, we will provide a written response to it. Okay, Andy?
Yeah, I think it's only fair to the gentleman asking the question to actually provide a full written response. It certainly gives some assurance at the moment that we're working on the detail of that. When it comes to implementation of NICE guidance, we do have primary care. When it's pertinent to primary care, we do have systems and processes in place to support that and enable that to happen. Medicines management, there's a lot of rigor around that. We do have medicines management committees. We have an area prescribing committee who look at this diligently. I do know as well in primary care, as a physician, we frequently look at least annually look at our list of patients, and it's reported back through our anticoagulant services to look at and report back all the patients and how long they've been within the INR range. And we can make decisions on that. So there are some fairly robust processes that practices go through, but certainly I think it's only deserving of the question to actually have a formal written response from our medicines management team, and they're close to coming to a final script on that one.
Thank you very much. That's helpful. I can't see anybody else has got their hand up. I've got nothing in chat, so we'll move on and we will provide Mr. Feldman with a written response, a full written response to that. So thank you. That takes us to page 11 of your pack, which is item 3.1, is the chair's report. So you have the report in front of you. I suppose the largest item on there is a discussion around the joint commissioning committee across Cheshire and Merseyside. We agreed in principle to the formation of a joint committee at a previous meeting, but collectively expressed some concerns that the membership of that committee needed to better reflect a CCG governing body, and there was no guaranteed either clinical or lay representation on it as it was previously drafted. So that has been rectified, and you can see in there how that has been done. So it's not really it's the chair's report. I'm not asking for a decision. I'm reporting back and gathering if there are any new concerns and a general feel as to whether the ask of the governing body has been fulfilled by those amendments. You'll notice that The next step would be to discuss this with our membership, because it requires a constitutional change, and clearly membership are the body that can agree a constitutional change. I'm not proposing that we rush to do that, because I have a feeling that there may be further changes and further development of the joint committee which will require us to go back to membership again, and so I think we might pause on that. I don't think the joint committee is in a position where it's needing to make formal decisions at present, and so I think we can hold off that a little bit. So that's my proposal on that item. I don't intend to highlight the other items in the report, probably with the exception that there is a process for an election of a colleague to join us on the governing body. We had 2 people stand, as you know, and that process has now closed, and so we do know that the voting, but the candidates haven't been informed yet, so we've not had that discussion, so I can't share that with you at the moment, I'm afraid. But we will be able to do that shortly when the candidates have been informed, and we'll have somebody new joining us hopefully quite soon on the governing body as a clinical representative from general practice. I'll take any questions. No questions? Okay, thank you very much. We'll move on then to page 15 of your pack, which is item 3.2, which is the Accountable Officers report. Claire.
Thanks, Andrew. Good morning, everybody. So this report always outlines work that CCG officers do that isn't covered elsewhere in the paper in the governing body meeting. So update on COVID-19, and obviously when this was written, the world has moved on, and I guess that we just have to sort of live with the fact that it moves on at ever-changing, fast-moving pace. So in terms of Cheshire, we're obviously now in an enhanced sort of response situation. Although the vaccine programme, and I'm sure Tracy can pick this up later in questions, continues to do a brilliant job. The incidence of the Delta variant is high in Cheshire, and this is recognised nationally, and it's also high, increasingly high across Cheshire and Merseyside. So a lot of work to do, and a lot of fantastic work being done on that with our partners. But as I say, things change every day, really. In terms of our COVID-19 group, Matthew's going to pick up terms of reference in the next agenda item. You can see we've got sort of good governance around this, and we continue to be audit and inquiry ready for the national inquiry, which will come. And obviously, there are requirements for that and for all committees during the pandemic, but I think we sort of are in a good position for that. Again, long COVID has moved on since the writing of this report. A national publications come out. It came out, I think, on Tuesday. So we will work through that with partners locally and across Cheshire and Merseyside. There has been additional funding, as you can see, and there's some additional funding for young people as well. But in terms of the current position, we have the long COVID assessment hub at the Royal Liverpool, and some support for children at Alder Hay. But really the priority for us is how we care for our long COVID patients locally. And that's with our respiratory teams in the community, amongst other things, but recognise that the impact on general practice is great and will be great. And I think it's the unknown with long COVID, and that's one of the problems that we will have to deal with over, I think, for the foreseeable future. I think long COVID coupled with mental health is just something that is a sort of a post-pandemic sort of responsibility for the system. Vaccination programs, as I say, Tracy can answer the questions, but we've made fantastic progress continuing to. The modelling is going really well, but the vaccine supply isn't. So we have challenges in terms of vaccine supply for Pfizer and Moderna, which obviously nationally you'll know the advice is for people under the age of 40, the advice is sort of an AZ alternative. So we are lobbying hard, and our directors of public health are lobbying hard and working with Cheshire and Merseyside in the region and nationally to try and get more vaccine into Cheshire. Obviously, the Prime Minister's announcement on Monday in terms of unlocking or the delay in unlocking, but then still asking us to vaccinate all eligible adults over 18 with at least one vaccination by the 19th, and 2/3 of the population to be double vaccinated by that date, puts real pressure on us. And so the new roving model and the pop-up static clinics, and the fact we've got pharmacies that can offer Moderna, Pfizer, as well as AZ, is positive. It gives us greater access and outreach and inreach, depending on which way you look at it, into the communities. And I think, you know, a really good example in terms of the first pop-up clinic, which went live a week ago on Monday, where 166 people in the Northwich area who hadn't been vaccinated, over 40s hadn't been vaccinated, you know, got their first vaccination, which is brilliant in terms of that really close community work. And I think Tracy was on television earlier this week for a little 3-second snippet, but got the message across in terms of it's never too late. I think much more accessible than an evergreen offer. I think never too late needs to be the new sort of mantra, really. So lots going on. Well done, Tracy. Yes, lots going on, and we continue to do a really good job. So thank you, everybody, for all that work. Got the workforce metrics there. You can see sickness absence has risen a little bit between March and April. We continue to investigate all of the sort of sickness absence, but you can see that stress, anxiety, and depression has decreased a little bit. So that's positive. So ongoing work through our HR ops group, and obviously each of the directorates takes this incredibly seriously and works with all its staff. There are a small number of people on long-term sick, which is affecting the numbers, but clearly in terms of an organisation like ours, anybody off sick, whatever reason, is a concern, and we support them. Just before half term, we had our annual assessment assurance meeting with NHS England Improvement. So the exec team, our chair, and Andrew Wilson and Andy McAlvey and Peter Monday attended that. And I think we did ourselves proud. So massive thank you to everyone who prepared and helped with the submission document, which the regulators said was the most comprehensive and detailed they'd received. So thanks for all the work. I know Dylan Murphy coordinated that, so thank you to Dylan. And then for everyone's efforts and contributions at the actual assessment. And it was only about an hour, which I think is positive and good news. And we're meant to be getting a letter later this month. I keep looking at the bottom right-hand corner, so it's the 17th already, isn't it? So in June, officially. So once we've got that, we can share that with governing body members and the wider system. And finally, you will have seen launched, hopefully, our bespoke In It Together campaign, which is to encourage the people of Cheshire to put some kindness back into general practice. I mean, the last 15 plus 16, 17 months, however long it's been now, in terms of the COVID pandemic, has been exhausting for everybody. And this is something we've been really passionate about, and we've listened to our practices, listened to our GPs, our practice managers. And so we're really proud of the campaign, and thank you particularly to Katie Brownbill for leading that through. But it's something that's been picked up by the Cheshire Merseyside ICS as well. So I think it's multi-channeled. You'll hopefully have seen Dr. Wilson's smiling face in a number of local newspapers over the past week, launching it. But it's something that I don't think, it's not just a single week or 2-week campaign. It's something that we, in terms of our appreciation for our practices, as well as all our other provider partners through the pandemic. But obviously as a membership organisation, this is something we're really keen to promote. So thank you. That's it, Andrew.
I'll take myself off mute. Thank you very much, Claire. Are there any questions for Claire? I got questions from Pam. So Pam, do you want to come in?
Yes, can I just ask a question on the workforce metrics in 3.1? Just that I don't understand the female to male ratio. I don't think that looks right to me. And I don't know what percentage of planned leavers are. What's that measuring?
So the planned leavers are leavers we were aware were going to leave.
Okay.
And in terms of the female male, Oh, hang on. Can somebody else help with that one, please? Because I have to say, I read it this morning again. So it's 3.77 females to every male, or 3.65 females to every male. So the workforce is nearly 3/4 female.
Okay, it just didn't, I couldn't work that out, sorry, thank you.
Maybe it's how it's presented, but it's basically, you know.
It would have been better if it had just been a ratio like 3 to 1
Yes,
or 2
no,
to 1. Or...
Agree. Yeah, it's nearly 4 to 1.
Yeah, thanks.
Thank you. Fiona, you have a question?
Hi.
Colleague,
Well,
introduce yourself as you start.
Is that okay? Can you hear me? So it's more of a comment, really. And I know you didn't mean this, but Claire Toll, when you said put the kindness back into general practice, the point of the In It Together campaign is that people are kind to those of us who work in general practice. Not that we've been unkind in general practice and you want us to be more kind again. And it's not even so much to the GPs as to all the staff, etc., who are taking it. It was just the way, the expression, that was all.
Okay, maybe it's how I said it, but it's not how it's written. So I think it's, you know, the writing is clear, maybe the talk over wasn't, so apologies for that. But I did say we had discussed this with our practice staff and our practice managers and GPs. So, okay.
Yes, lovely. More kindness all round, everywhere, and the world is a better place.
Indeed, for everybody, including those who present.
Including those that present. Right, any other comments on Claire's report?
Leslie's got a hand up, Andrew.
Leslie.
Apologies, my chat box isn't working. So just a couple of questions about COVID. I just wondered what the impact has been on the hospitals with the increasing rates of COVID in the community, or whether actually the vaccine campaign's working well and we're not seeing those admissions and that the people are either sort of asymptomatic or, you know, mildly unwell and are able to be managed in the community, because that would be a positive thing. And I suppose when we're going to start to look at that rather than the rates in the community, because this is something that we're going to have to live with long term, and how we move to do that, really, because I think it was always about protecting the NHS and protecting patients, wasn't it, and people from becoming seriously unwell from this illness. So that was just my first couple of questions. And then just about long COVID, whether there will be an offer more locally for our patients, because again, I think I mentioned before that Liverpool's a long way to travel for a lot of our residents, and whether there will be something in the future that we can access, because I think we have tried with local hospitals and they've redirected us to Liverpool. So thanks, Claire.
Okay, so I'm going to start answering those, and I'm sure both Tracy and Anne McAlvery will put me right on the answers. I think in terms of the incidence at the moment, hospital rates haven't increased that much because the incidence has gone through the younger population who haven't been vaccinated. So I think we can be confident that the vaccine campaign has worked. So we know in Bolton, unfortunately, those who were hospitalised, it transpires they hadn't been vaccinated, or had only had as a minimum one, but on the majority of those who were hospitalised hadn't been vaccinated at all. But the incident rate for us in Cheshire seems to be with a younger population who haven't been vaccinated yet. Hence the sort of the rush to roll out the I think it's under 21s and under 22s at the moment, and probably by the end of next week it will be all eligible adults over 18, so we can move that forward. And I think that's clearly the message that the Prime Minister gave on Monday in terms of unlocking the roadmap unlocking, so get everyone over 18 vaccinated. So I think hospital rates haven't increased, which is positive, but clearly we need to keep an eye on that. But that doesn't mean in terms of recovery and restoration that the system isn't being taxed, particularly in terms of urgent care at the moment. But I think the vaccine programme is proven to have worked, but I think they never give up, not never give up,
Too late.
Sorry?
Never too
Never
late.
too late.
Never too late, but never give up either. Never too late campaign stands, but I think it is in the younger community. In terms of long COVID, yes, Liverpool's a long way away. And I did say in the talk over in terms of it is about what we can offer our residents in the community locally. So I think we need to have a look at that. But the national publication only came out on Tuesday, so we'll read that alongside everything else we're doing. But I know, Tracy, you might want to come in on that. But I think we would want to provide as best care as possible for our population close to home. So I agree, Liverpool and Alderhay is a long way. Tracy, do you want to come in, please?
Yeah, happy to. So yeah, I think Claire, what you said, that absolutely spot on in terms of the first part of the question. The hospital have seen some further admissions, but not to the rates that we saw previously in the year. And yeah, there is anecdotal evidence that it links to those that have not had either 1 or 2 doses of the vaccine. So it reiterates everything we're saying, which is go get your vaccine and make sure you have 2 doses. The further wider impact though is on that often we've got families that are all isolating as a result of the younger person, the impact on those younger people, and also then workforce issues that then entails. So I suppose it's not just about measuring hospital admissions, it's about the impact on our communities as a result of those rising cases. In terms of long COVID, it has been commissioned by Cheshire and Merseyside, so it's not been commissioned by Cheshire CCG. It's about doing it once and doing it on a wider basis, and I think that's meant that very quickly we can get that service in place. I say we're a co-signatory to that rather than the lead commissioner on that. I think our role in that is to monitor what we need locally and make sure at the review point, which is mentioned in the report, mid-June and then further on, that we then look at what is needed specifically for Cheshire and other localities in Cheshire and Merseyside. So I don't think this is a permanent fix. I think it's get the service off the ground, see what the demand is and what the long-term impact is and the long-term need, and make sure that there are local services. So I don't want that to be seen as that's it, you know, we've ticked the box, and it's about us then making sure that we've been very clear about the local services and then what we require that is needed in Cheshire as well.
Thank you very much. Are there any further questions regarding Claire's report? No? Thank you very much. I think that means we can move on. Did somebody want to speak? No? Okay.
Andy,
can we just start?
Sorry, just from a medical perspective, Andy, Leslie, thanks very much for the question. I think, you know, Claire and Tracy have actually talked about the vaccination program and its success, and absolutely laudable and should be encouraged. I think there's been, if there's anything, a little uptick. I think some of the hospital patients have actually not needed ICU facilities as much. It's more ward-based care, which is really encouraging as well. I think we need to, you know, but with what we're seeing, and we're looking at this really diligently, really closely, and we need to still look back at our patients in the community who are still vulnerable. So although there's some data validation issues that we need to work through as well, it's still looking at those high, you know, nursing home patients and checking back and making sure that they're in the safest environment possible and they've been vaccinated. So it's almost, you know, if we still concentrate on those, you know, I know the focus and the public focus tends to be on groups 11 and 12 at the moment, but actually that check back is absolutely crucial because our nursing home patients, our residents there, are the ones that still get the most benefit, and we've still also got to concentrate on that cohort.
Thank you, Andy. It's a really important point. And I have heard this. If this is the fourth wave, if that's what we're calling it, if that's what it becomes, that the fourth wave is the community wave, and it is going to be one that is, you know, the response is going to be a community response more than a hospital response. So an interesting perspective. Thank you very much for that comments, colleagues. And just to read out in the panel, Suzanne has thanked you for a good report, Claire. So we're just spreading the love and kindness. Before we move on to item 4.1, which is on page 22, and it's the COVID executive terms of reference. So I think Matthew is going to guide us through this.
Thank you, Andrew. Matthew Cunningham, Director of Governance and Corporate Development for the CCG, for those watching. Hopefully, won't spend too long on this item, but as the governing body is aware, we have set up this COVID-19 recovery group and has been operating for some time. And by the changes to the scheme reservation delegation, Claire and Linda have got increased authority to make decisions, financial decisions in relation to COVID. We've recently reviewed the terms of reference for this group and highlighted in this paper the main changes really in terms of memberships now includes the ICP representatives as voting members rather than just being in attendance, which is a change from last time. We've also changed the frequency of the meetings, which were in effect weekly, once now fortnightly due to where we are currently with COVID. We've also more closely aligned the terms of reference to what's required of us by the 2021-22 priorities. Why we bring it to you in some respects. So again, whilst not a committee, it is a key decision-making forum, and taking into account what we've just discussed around being audit inquiry ready. It's good practice to make sure that you're aware of these changes. But also, it's not really good governance for us as an exec team to sign off our own terms of reference because we make up the majority of the membership on this one as well. We also wish to publish these terms of reference, and that was a change from last time. So again, ensure full transparency, and subject to approval, these would be hosted on our website and our governance corporate handbook. Happy to take any questions, and I'm sure my colleagues who also sit on the group can also answer questions as well. But just asking you to update these, approve the updated version of this terms of reference.
Thank you, Matthew. Peter, you have a question.
Yes, thank you, Chair. Apologies for lateness, by the way. I was having trouble getting in. My question really is around whether it might be better to run this at place level. Obviously, constituting it may be one thing, but whether that could be held in the background as a possibility. Because obviously we know we've got both local authorities there, we've got both ICPs there. I mean, I realise it will be an additional overhead, but would it be better managed at place level?
Claire,
I'm going to say no.
I'll say, Peter, because obviously we have partners at the table who operate across both places, there would be something about duplication if we had more than one meeting. So the updates that we do get from the two ICPs are at place, but as I say, we have one, we have numerous providers working across the two places, and whilst the CCG is responsible for what it is, it does make sense to do it at place plus. But I can give you assurance we do drill down and understand what's going on in both places as well.
Andrew, can I? I think I crossed over Matthew and I said no. I think we should need to manage it on a single Cheshire footprint. We are still the Cheshire CCG. We have reports in from the ICP, from the outbreak boards, the protection boards. I think we need to be pragmatic with this. We have a single Cheshire steering group that Tracy chairs every Thursday in terms of the programme with all system partners. And I think this is hopefully a sort of, if I'm honest, a temporary solution, a temporary governance and a temporary committee. So I think it's working well. I think the updated terms of reference make it as transparent as possible in terms of having ICPs now voting, and I think we just continue to work and we can report back and we work into place and through place. But I think a single committee holding the ring feels much more sort of comfortable and pragmatic to me.
Okay, Peter, do you want to come back on that, or are you content with that? Content, thank you. Okay.
Andrew, you've gone on mute.
Got on mute.
You're mute,
I was
Andrew.
going to say, are there any further questions? And if not, yes, Pam?
I just, Claire's just called it a committee. I think it should be a committee of the governing body, not a working group, especially given who's on it and that it reports to the governing body.
I think, do you have a view on that?
It can be easily done. Called it a committee and put it on the architecture. That's not an issue. As Pam said, we report back its decisions via Players Accountable Officer report, so you get sight on that. We can call it a committee if people are comfortable with that. It's no major change.
Okay, Peter's put in agreement. I suppose my thoughts would instantly be we can fine, we can do that. It might seem strange to have the COVID executive as a committee of the governing body, but not the executive as a committee of the governing body. So that's something you might think. Suzanne, did you want to mention anything? I don't want to spend too long on this item. It was a 5-minute item and it's a term of reference, but Suzanne.
Yeah, I did ask him, but I think you've missed the chats. Could I just ask just a minor point really about consistency, what we're calling this, because we talk about a COVID executive terms of reference, then we talk about a COVID recovery group. I just wanted to make sure we were talking about one and the same thing throughout the report. It got a little bit confusing, so just a minor ask. And the exec's not a committee, they're either executive team or executive group. There isn't really an executive official committee as far as we're aware, so if we could just sort of clarify the bit of semantics on titles, that would be great. Thank you.
Thank you very much, Suzanne. My apologies for missing your chat. I've looked back and it is indeed there. My apologies. Right. I think we are asked to approve these, and I think we are doing that. But we're asking for further consideration that should this be a committee and for it to be tidied up in terms of nomenclature and semantics in terms of the wording. Are we in agreement with that? And we can otherwise approve it. Thank you very much. I think we can do that. We can move on then to the next item, which is 4.2, which is on page 30, which is the governing body assurance framework. I'm going to hand over to Matthew in a second. I just want to say thank you to the committees first, for clearly committees have been reviewing this as we agreed and have been updating the GBAF, which is great to see. From my perspective, I think we do need to probably stop and reflect on some of what we have got in our GBAF, and I think the item on climate change it really strikes me in that what we're sort of saying is we had a great ambition for climate change. We know that we're going to be disestablished. The present difficulties, that ambition is being reduced. I suppose what I'd like to say is, well, actually, have we really thought what our new ambition should be? What can we deliver? How are we going to deliver what it is, even if that is a reduced ambition from what it was previously? So with that in mind, I'll hand over to Matthew for the governing body assurance framework. Matthew.
Thank you, Andy. I'm sure the people might wish to chip in around that point around the environment, but as Trust and ICSs have to submit a plan very soon about how they're going to get to, neutrality by 2040, I think it's a really important one. And our previous conversations around the ICSs, the CCG, and the CCGs, the ICS, it is still the same here. Yeah, and the fact we're leading a lot of this, needs to be taken on board. So I was also going to start with a lot of thank yous as well. This is the first quarter report of the revised Body Assurance Framework process, which was signed off in March by the governing body. Lots of people involved, so especially I'd thank Phil Meakin, who's overseen a lot of this, along with all the risk leads, and a big thank you to all the chairs and all the committee members who've taken a really active part in receiving the risks, reviewing the risks, agreeing the position on it to bring back to the governing body. So hopefully you've been able to see through the report, there's been a lot of rigour in making sure we've spoken to lots of people to make sure we are happy with this. So what's being presented to you today is not the position of me, it's not the position of Phil, it's the position of the oversight committees and the exec team and the risks that have been assigned to them. So I think there's been a great deal of work done. I do take your point, Andy, we should always be agile, we should always reflect our risks right now. They might have been 3 months ago, but the world keeps changing. So I think those are the conversations that happen at the oversight committees correctly. and they do affect some of the risk scores. You will see from the report that the committee is suggesting changes to three risks. My first apology here is that stubby fingers Matthew should have put, governing body risk number 10 instead of number 9 as the one that has changed. So the three ones that we are changing, which doesn't get reflected necessarily in the cover report, is 01, which is around Commission Environmentally and Sustainability, where we're suggesting an increase of risk from 16 to 20. Strategic risk number 10, which is around clinical leadership. I've put 9 on the front cover, so please forgive me on that one. That's a risk from 8 that was agreed at March to go up to 12. And then strategic risk number 11 around the challenges of that pandemic thing. I'm being shorthand here. Is a reduction of risk from 20 that was agreed in March down to 16. My last apology before I open up to any questions and ask for approval is that in the Appendix 1, which has got all the greater detail around the governing body assurance risks and summary of what's changed, the last risk, risk number 11, the box detailing the changes was cut off when it was formatted, and it wasn't reflected in the main report as well. So I just thought I'd just read out what those were, just so you're aware of it. One of the reasons why we suggest a reduction to 16 rather than 20. The national major incident level has gone from 4 down to 3. Our incident control centres can scale back their hours, and we've done a number of lessons learned, sort of meeting with partners around COVID as well as flu, and the learnings from that is being taken forward to how we manage a pandemic going forward. They were the reasons I believe that we agreed to reduce it down to 16 or suggest 16 to yourself as well. So with those apologies, hopefully equally you recognise a lot of work that we've done to get us to the position today. The ask as outlined in the paper is for you to approve the risks as they are and the suggested changes from the committees. I'll open up to questions, please. Andy?
Thank you very much. Questions, comments, observations, please, from colleagues.
I believe Peter's got an ask. Oh no, sorry, legacy.
Claire, do you want to come in?
You're on mute, Claire.
Firstly, I'll put the microphone on, and secondly, I'd like to say, just to sort of reiterate Andrew's thanks. I think this is so much better, and it's really good progress, I think, in terms of governing body approach. And I'm also pleased it's higher up the agenda, because I think we've always talked, haven't we, in terms of it always gets hidden at the bottom and then we don't have time for it. So I think it's about the importance of it. I'm happy to support the changes. I think they're realistic and pragmatic, and I think the fact they've been supported by the execs, worked through the committees and by the support officers, I think it's a helpful process. So I think they're reasonable changes that I would support. So that's what I'm saying. But I think just a big thank you really for the work. I think it is a comprehensive approach now. But I think Andrew's point in terms of not waiting, and we need to keep these sort of live, each of the risks. So I think there's something maybe that we need to do as an exec team to have this on the agenda. And routinely just review some of the risks and just discuss them as an exec team. I think that would be helpful, particularly when Andy and Sinead are part of the discussions. So I think if we can table that, it keeps them, I think, it's just live, aren't they, as I said. So thank you.
Thank you very much. Paula wanted to come in.
Thank you. The point I wanted to make really was about the link to the operational risk register and just some learning and reflection from our committee. And that really was about when you pay attention to the governing body assurance framework, it does stimulate thoughts around the operational risk register, and actually that's the starting point for us in terms of understanding the detail and the depth there. So I just wanted to share some learning there from our committee. And the other point as well is that for programmes of work that don't use sort of a programme management approach to deliver some of their work, actually, Claire's point about raising these regularly at the exec team meeting does then alert you to thinking about operational risks that you may want to revisit or put on the operational risk register. I think the structured approach for some of the areas that deliver their work through the programme office have that afforded to them as part of their structure. But I actually think it would add value to some of the other directorates to stimulate some of that debate about the operational risk register. So I think that's a really helpful point. Thank you.
Andrew, could I just come back on that, please? I think there's something, and thank you for that, Paula. I think there's something, isn't there, in terms of that corporate ownership. If you do this too much sort of one-dimensional, one directorate, one committee, we've always said in terms of the role of the exec team is, you know, sort of individual directorate responsibilities, but it is that corporate role, that corporate operational committee. So I think we just need to table it in. So thanks for that support, Paula, on that, and thanks for the comments and the learning through the Quality Performance Committee, Quality Safeguarding Performance Committee.
Thank you. Peter, want to come in?
Thank you very much, Andy. When we merged as when the four CCGs came together, we sort of pooled our risk registers and assurance frameworks. And just thinking ahead to next April, and thinking about targets, if you like, things we should be trying to achieve this year, particularly with regard to climate change, is that one of our aspirations should be that that risk goes on to the ICS risk register and assurance framework from the word go, and that we don't lose it, because I suspect that not all the CCGs coming together in Cheshire and Merseyside have this as a higher priority as we do. So I think you know, whether we sort of flex the wording a little bit to reflect that, but we ought to make sure that this stays on the agenda of the successor body.
Absolutely, I think that's really helpful. I think some of the one I was saying, how do we change our plans to reflect reality, is some of that stuff. So how do you make sure it's on the risk register of your successor organisation? How do you go and influence the two places? You know, does a governing body delegation say, could we come and speak to the partnership board in Cheshire East and whoever, you know, perhaps the SNP in Cheshire West, and say, can we come and talk to you about climate change, or can we come and talk to you about some of our other ambitions, because we want them to be things that continue to live after we are established. It's those sort of things, whether we sort of rethink some of the action plans around some of these things, not so much into we will do, but we will do what we can, but we will influence others whilst we are still organised. Okay, don't think I've got any other points unless I've missed anybody. We could tempt with that. So tempt with the changes to the suggested changes to the risks, but as importantly, more importantly, we contend that there are action mitigations in place to realistically affect and correct those risks. If not, Andy.
Thanks, Andy. Just on regard with some of the risks going up, I think clinical leadership is one of those things, and it's a domain that Sinead and I lead on at the moment. But as it is perceived to be going up, and with the threat, not threat, but, you know, we're engaging and embracing change towards us being ICS, I think that behoves all the clinical leaders, certainly on the governing body, and including yourself, in how we embrace that as a clinical leadership. So although I think Sinead and I are comfortable with actually having our names against this, I think it's how do we galvanize all the clinical leaders within and on the governing body, because it is certainly governing body GPs do hold that responsibility of membership with their GP practices. And that was the one question we asked the new member coming on to the governing body: how would you engage with your member practices? So probably galvanizing that and probably working a bit more acutely and a bit more closely together on that one as we go forward in the next 3-6 months. Thank
you very much. Really important considerations. Yeah, and certainly I'm happy to engage you doing that. I'm sure the governing body GPs and all governing body clinicians are as well. Yeah. Lovely. So we are asked to review, which probably we've done, approve the changes. I'm not seeing anybody dissenting from the agreement to those changes. Consider the controls and assurances, and note the review and assurance processes. Are we all content to agree with those statements? I'm seeing lots of nods. Nobody seems to have a problem, so we will take that as agreed and move to section 4.3, which is on page 89 and is the commissioning of community-based capacity to support the COVID response / recovery. And it is Andrew McCalvey and Jackie Wilkes. I did see Jackie appear and she's just reappeared. So welcome, Jackie. I don't know who's leading off with this, so I'll open it to whoever's going to put their hand up and lead on it.
I'm more than happy.
You're on mute.
On mute, Jack.
I'm not now. Thank you. And so shall I start, Andy, and then Andy will come in and support as and when. So thank you very much for inviting me today. I'm here today to present proposals to continue to provide investment throughout Q2 for this additional capacity community services, and this is to meet the rising demand for urgent care, which we are seeing, and certainly we, every morning we are talking about how we try to get in there and manage the demand, which is rising all the time. But it is about maintaining flow through hospital services, not just for those patients who have urgent care needs, but also those who are on the receiving end of our elective restoration programme. So we'll pick that up as we go through. So I thought it would be helpful just to pull out the main points in terms of where we currently are with urgent and emergency care. We are seeing a rising demand, and there was an urgent call this morning around A&E attendance as one of our trusts this morning, which is unprecedented, I think would have to be said. So there is a constant challenge around flow and performance across the three organisations. We did see during Q1 when the home first model really started to bed in, and this is this idea around the focus on discharges and getting people out of hospital as soon as possible. We did see an improvement in flow, and there was evidence to support that we were not only reducing the length of stay, but actually we have a capacity to support more people to go home the sooner we get them home, but that actually we needed to shift the current model that we've got, which is almost an over-reliance on community beds, to that home with support programme. But we are seeing some challenges at the moment around that, particularly with domiciliary care and reablement. And interestingly, what we hadn't really foreseen was the impact of the reduction in restrictions on COVID, which we're seeing people who had migrated to dom care as an employment going back to entertainment, travel and retail and hospitality. So we are now seeing a shift away from dom care, which is a bit of a challenge for us, but we do have some plans and we do have some actions around that. You will probably aware that we're seeing an unprecedented demand on mental health services, and for the first time ever since I've been in Cheshire, we've got patients who are being placed out of area, which is unheard of for Cheshire and Merseyside, Cheshire and Wirral, and we're looking at patients being in A&E departments for up to 2 days waiting for an appropriate placement. This isn't great. It isn't great for patients, and it certainly isn't great for the staff and the other patients in the department. So, wanting to really get on top of the mental health issues in addition to physical health capacity. We know that all three hospitals have developed and are implementing their elective care and cancer restoration programmes, and that is absolutely vital that we protect that programme, and which we do know that rising demand for urgent care puts that programme at risk in terms of competing for capacity on our bed-based services. We've had recent public health data that is predicting, and we're starting to see it already, a rise in respiratory conditions, particularly in young children who have bronchiolitis. So you're looking at the under fives. The problem we've got with this is it mimics COVID. So at the point of assessment, we're not sure whether it's bronchiolitis or COVID. And that would suggest that we need to think very seriously about the arrangements that we currently have in place to separate COVID from non-COVID patients. And that will feature in our plans moving forward in our proposals. So that's where we're at. I think it would be helpful now to summarise what we are intending to do and what our proposals are. So we have had during COVID the establishment of hot hubs, which enables primary care colleagues to separate COVID from non-COVID. We have a national standing operating policy that requires our primary care colleagues to do just that. And we're waiting for renewed guidance around that, but at the moment that is a requirement. So as part of the proposals, we're suggesting that we need to keep those arrangements in place. We definitely need to continue the home first model if we're to maintain flow through the hospital, but we are currently looking at ways of increasing our capacity within pathway 1, which is enabling people to go home with support rather than this, as I said before, the over-reliance on community beds. But we do need the community beds in place, and this is to enable us to get people to step them down from the acute hospital and undertake any further assessment of those patient needs in the least restrictive of environments. So it is around, but with the discharge to assessed beds, we do put GP cover and therapy support around that to ensure that we maintain those outcomes for those patients. And we actually feel that we need to retain a ability to set up a designated setting, so within that discharge to assess facility. So during COVID, for those patients who could be discharged out of hospital, were stable, but that were within their isolation period, we had a designated setting within the care home sector. And our proposal is to keep that facility going, but given that there are no current demand for those services, we've negotiated with one of our care homes a retainer scheme that enables us to retain 3 beds should we need them, but at a significantly reduced cost. Therefore, we're asking the CCG governing body to agree to accept the risk of a shortfall in funding through the Cheshire and Merseyside Enhanced Discharge Fund, which has been made available during the COVID pandemic and has extended into Q2, which supports all discharge initiatives, but with the maximum risk of being the full spend of the extended discharge schemes at a cost of £913,337, and the ongoing funding of primary care hubs, which is in the financial plan for the CCG, which is around 275,000. We would ask you to agree the approach to designated setting, which is a retainer arrangement, recognising that on the retainer that's a cost of around 33,500, but if should we reinstate those beds for the for any potential outbreak, that cost would rise to 122,000 because we would need to put the wraparound care back in and the cost of the beds would go up. We have a number of, in the paper, a number of next steps to, in terms of what we're going to do to help us build that capacity in pathway 1 and how we're going to manage urgent and emergency care through to Q2. Thank you very much. I'm happy to take any questions you may have.
Right, before I go to questions, Andy, did you want to add anything, or can I move, as Jackie did a marvellous job, and move to...
Just to say, Jackie's did a really good job. I think it's an exceptional paper. Thank you very much, Jackie. I think the overview was very good. It's not where we want to be. We did approve Q1 funding, and we'd hoped that this pandemic would get under control, but actually we've had to be flexible because monitoring the variants. I think we're all aware, you know, going from this week and last week, how this thing can change very quickly. And so, you know, we didn't anticipate that we'd have to do this type of thing, but I think we've had to be flexible, and that's the reason why we're coming back now. So I can't say this is going to be, we can't come again in another quarter. I don't know where this pandemic is going to take us right now, but I think we're doing all that we can. But I think it's quite clear some of the asks within the paper. I think the hot hubs themselves, although utilisation, and there would be there'd be varying clinical opinions on this, certainly 2 or 3 weeks ago. But actually monitoring this pandemic and monitoring some of these cases, I think we'd certainly have to take a cautious approach. And as the standard operating procedure for primary care hasn't changed, I don't know where some practices would have any idea of how they're going to cope with both COVID suspect patients and the other population of patients, especially as general practice has been asked to, work more towards a business as usual and all monitoring long-term condition management. So there are definitely pressures within the system, definitely in the community, and we do need to consider this investment. So any other questions, myself and Jackie are more than happy to take. Thank you, Andy.
Thank you. So I'm going to go to Gwyd first, and then to Tracy, and then I'll ask Linda to come in on the finances and risks around finances. So Gwydion.
Thanks, Andy. Gwydion Rees, Governing Body GP. Thanks, Andy and Jackie. I thought that was brilliant, and it's music to my ears as a clinician in community services. I've got a very brief question on the discharge service, and it is a slightly different ask, but if it's not being used to saturation, is there a capability to adapt it so that it can offer some more in the way of community intervention beds? Because then it avoids a patient going to hospital in the first place if there's sort of a midpoint. So that was the first question. And then on the primary care hot hubs, Andy started to elaborate on it. If I could see, or if the body could see at some point, a bit on historic performance and looking to see when the services are saturated, usage by area, so that we can get some confidence that it is fit for the challenge of this fourth wave, which I agree that it's looking as though it's going to be a community wave. And on top of that, there's obviously the concern about the rise in respiratory illness, especially among children. And really it's about the justice aspect. So making sure that the services are fair so that we get the access that we need to the most disadvantaged communities. I was also wanting to know, just get some clarity, if a patient hits an A&E environment, because we can see that the weights are going up and up and up, are they actually redirected to the hot hubs? If they are, again, how does that happen? How do they get there? Simple things, really, which again goes into that justice aspect. Do we have any service user feedback on the hubs? Do they work for that service user? And then Andy started to talk about it. It's a big challenge at the moment about the clarity with regards to when should we see someone face to face, how should we see someone face to face, and how do we deal with these two patient groups that we're supposed to sieve out? And are we as a CCG, whilst waiting for national guidance, which always arrives late, are we going to try and be a bit braver so that our providers can actually put something robust in place? Because I think there's a lot of confusion in general practice at the moment and a lot of mixed messages nationally. But as I said, really happy to see it, and possibly some ignorant questions on my part. Thank you.
Can I start with some of that, Andy?
Yeah, well, let me just, Fiona's also got a question on hot hubs. So we hear what Fiona has to say, and then perhaps you might be able to answer more than one in the go. So Fiona.
No, my question about hot hubs was exactly that, actually. It was about that, and also the reluctance that some people have of going there just because it's quite far away, and the public have forgotten that it's there, to sort of make sure that COVID positive patients don't end up in other community settings because they're forgetting that that's what the screening questions are for now. But otherwise it was all what that's just what Gwyd just said.
Thank you. In which case, Andy, please, yes, do respond.
So absolutely. I mean, see, these are it's how we actually get the system to connect, I think. This is one of the crucial things, and why we've got, we do come together, we come together as an A&E delivery board, but actually, I think that's probably a misnomer. It's how do we manage urgent cases, and it's not just about accidents and emergency, it's about the whole system. So some of those conversations, and they are encouraging, they are actually supportive. It's how we work through with that. Sometimes we've got to think about how patients flow. Sometimes culture beats any type of strategy in any communication program for breakfast. So actually, where patients do hit in the system, we've got to have a consistent message. And actually, if they are actually attending A&E and they seem to be a more low level that's not needed within an A&E department, then there needs to be some, investment to actually manage those patients, and if they need to be connected to hot hubs, so there needs to be that easy. And that's some of the early thinking about where the best place to utilize and actually situate some of these. So yes, and then to Fiona's point about distance, it's difficult to actually, because how then do you manage a number of sites? Cheshire is a challenge. It is a very, very big place. And I completely understand some of the difficulties as well with fuel poverty and the transport issues and where need is. And we're continually looking at where is the best place to have this, and whether there does need to be, what kind of number is the ideal number. And again, it comes back to, and what have we got to invest? So we've definitely got the challenges. I guess it's, where are we right now? Let's look at the utilization figures. Let's still work with our other providers in the urgent care sector to make sure we've got those easy links for patients. And also, what else could we need to hang on? What other services do we have to have in place? Because the oximetry service, if that's going to start ramping up again, then we need to have some type of infrastructure within the community to actually to utilize that. Otherwise, it's very difficult to actually deliver. So I haven't got a great deal of answers to some of your points, Quid, but actually, I'm sure we'll get that to you and actually get more figures and numbers. Certainly, as the ICPs are actually delivering some of these services. So, but thanks for the points. We'll take all that back as well.
Thank you very much. I'm going to bring in Tracy, and then Chris, and then lastly Fiona, and then we will need to, Linda, then we need to move on. But I don't want to hand over the chairmanship to Wendy too far behind our schedule, because that's very unfair. So Tracy.
Thank you. Thanks, Jackie. It's a really comprehensive paper, so that's great. A couple of questions. When we've looked at these schemes in the past, they've gone through either the exec committee or certainly the COVID committee. So I just wanted to check it's been through that route. And the reason for asking that is that I suppose what I'm concerned about is, I think a lot of the things that are in here I support, but I think there are other bits that I think we also need to draw in. So I'm very, very aware of the pressure on the continuing healthcare team who are being asked to support the sourcing of domiciliary care packages and other placements, and I think we need to play into that. So I certainly had a conversation with Linda yesterday about how we fund some of that support for our acute trusts, and if we use all the money to fund what we've put in this paper and we don't leave any funding for my ask on that, I'm a bit worried, and I would have made that point if I'd seen it at execs or the COVID group. So I suppose I really support what's in here, but if you could just let me know about that wider engagement, and then also how we don't make sure we've used all the money and not consider the things that I'm aware of that I think are another area of pressure.
Okay, thank you, Tracy. Yes, I think this paper, the time challenges around this, given that we haven't had our allocation for the year, and given that we are literally limping from quarter to quarter, trying to look at and evaluate the impact of some of our initiatives on the previous quarter and fitting in with A&E Delivery Board has been a significant challenge. So turning this paper around in just over 24 hours from A&E Delivery Board was a stretch. I completely agree that the process internally, we probably need to look at that, Tracy, to see how we could make that happen. But we need to have a little think about how we do that, given the timings on it. Hopefully, if we get an indication of the remainder of the year, proposals, guidance, funding, we'll have a little bit more time to take these through the channels. We could maybe have a chat about how we line up some of the dates outside of the meeting, and if we can't line up the dates, how can we make sure that we include everybody in the papers and proposals moving forward. So yes, this is absolutely completely right. This is a whole system issue across all the pathways, which includes the pathway 3s, which is a direct impact on continuing healthcare. They do sit on our system flow groups. which is helpful, which we have every week. We've moved to a place-based solution on flow rather than just the whole of Cheshire. So we're able to have those conversations, which is helpful. Maybe we just need to see how that infrastructure works.
Thanks, Jackie. Could I just come back on that, please, Chair, briefly? So I suppose just to state my position on this, which is I do support the paper, but with a caveat, which is that we do need to consider the impact on the continuing healthcare team, and if we need to allocate some resource to allow them to be able to function so that they support this, or that we are putting further support in our acute trusts. If we don't do that, I'm going to be back with another paper asking for a further cost pressure to be funded, and that's not intelligent commissioning. So I'd like to just put that marker in the sand now that we've then got a holistic view of this. It's not just continuing healthcare, it's about the sourcing of packages and domiciliary care, which is referred to heavily in the paper, but I don't want to mention that now and it be not mention it and it be an afterthought that's not included, if that's okay.
Thank you very much. So I'm going to go down to Chris, and then we've got Linda to discuss the finances on this. I have got an eye on the time, but I think there is then almost another question being raised. Is quite what are we being asked? Is there there seems to be some disagreement within the executive team potentially in terms of whether we should be agreeing this paper, and so what do we agree? I know you're saying we should agree it, Tracy, but we agree it with a caveat that is open like that. We're not really agreeing it, are we? So and is there a time pressure on this, and how do we proceed?
Yes, there is.
Let's take Chris's question, and perhaps we'll come back to you to discuss that. So okay, Chris, can we take your question, please?
Yeah, thank you, Chris Lynch, cooperative lay member. I think what I was going to ask, perhaps Andy covered that. I was thinking, as a layperson, not knowing the system, people going to to the appropriate place. I was thinking the likes of NHS 111 first, and what the effect of the crisis cafe is to people attending A&E for mental health in Chester. I think my real reflections are more concerns for the future, particularly around the background and the context. That are we seeing a surge or a peak, or is this a real shift in the levels of population health of the people in Cheshire? And that whilst we've rightly been dealing with the pandemic, and what's the effect of the lockdown been on people, and are we seeing huge changes in people's mental health as a result of that lockdown? Sedentary behaviour, diet, exercise, alcohol, substance misuse. And at what point are we going to know? Is it, we've talked, and Neil talked previously about reducing the waiting lists, but at what point is this going to add, and when are we going to know sort of what's the after effect, or is it just a change in long-term conditions? And I think that's just a reflection on being aware of that in the future.
Thank you very much, Chris. All very, very good points. I think I've got Pam to come in, Pam, and ask if you can be brief if possible, and then we're going on to Linda, and then the question of what we exactly are agreeing. So, Pam, please.
Pam Smith, I'm a lay member. I'm just interested in the capacity in these beds, because I'm aware that have been people that are stuck in hospital for some considerable time from my own experience. So are these beds all being utilised?
Shall I pick up on that? Yes, yes, they are, Pam. And so what we did was, as we moved from Q1 into Q2, we did do a review of capacity usage, and we have closed some beds, so that you will see that there is a reduction in some beds from Q1 to Q2. That said, recently we've had to increase our spot purchase because of the struggle to get Pathway 1 support. So rather than send people home without the appropriate support, or keep them in an acute hospital bed where the outcomes are going to be even worse, we have been utilising community beds just to get them out of hospital, to get to wait for their package of care and then get them home for their packages of care. So there is real pressure, and yes, all of those beds are currently in use. And to go back to Chris's point, it's such a well-made point. My gut feeling is that this demand is not going away, and anytime soon. And I think it's for all the reasons that Chris pointed out. And I certainly think the mental health issues, it requires a much bigger system response. Unfortunately, Cheshire and Merseyside are holding a summit to look at mental health and to work together on a demand management strategy, which I hope will result in more early intervention and prevention services. Thank you.
Lovely. Thank you, Jackie. So I'm going now to Linda. And Linda, I think the ask from you is to explain the financial ask here and particularly the financial risks to us here. And I wonder whether, if it is possible, and whether you can have any thoughts on, is it possible to accommodate Tracy's ask in terms of that some of this funding might need to go somewhere else? Is that?
No. So if we're, can I just sort of say that the £913,337, to be precise, is hopefully going to be funded by the HDP, which is the Hospital Discharge Programme. That is a budget which is held at an ICS level, and we have requested 10.4 million from that fund, and this 913,000 is part of that. There isn't funding in the baseline budget for that. The hot hubs, the 275, is part of our baseline COVID funding. So that is already in the position for H1. There isn't any additional funding that I'm aware of at the moment which would allow us to fund additional capacity in the CHC. So I think it is about looking at what we are spending and saying, what is our priority? And what do we not want to do? That's what do we not want to achieve? What do we want to do within potentially some of the other funding? Our ability to flex is very limited because most of the budgets we have are either sort of things like prescribing, where our ability to control, obviously we have the prescribing scheme, etc., is limited, or it's a fixed budget, such as the provider contracts, or which is also the GMS contracts, etc., which are all fixed. So our ability to flex is reduced. Thank you.
Thank you very much. Is everybody content, Claire?
So can I just, in my simple non-accountant brain, Linda, apologies. So what you're saying is that the funding that's been asked for is either within our budget, or we will be receiving the funding through hospital discharge programme monies. So this does not add any additional pressure to the CCG's position. And if that's the case, because I mean, we had this conversation at the A&E Delivery Board last week in terms of sort of short-termism. So, I mean, if that's the case, I'm very happy to support it. I want to sort of assure Andrew there's not disquiet or disagreement within the exec team. I think it's just that this paper has been turned around very quickly and we haven't had the opportunity to discuss it formally at the exec team. But Neil and I, obviously, I chair the A&E Delivery Board, so I'm fully aware of it, as is Neil. But I think we haven't had the time to discuss it either at COVID or exec team, which we would have wanted to do previously. I think Tracy's question isn't disagreement, it's about making sure this is a sort of a holistic approach to the urgent care pressures, not just the ones that are presented here. So I guess, Linda, the question is therefore, if this doesn't put at risk the CCG's position, very happy to support it. And I guess Tracy's ask is there sufficient, and I know there are conversations because we have a return to do to NHS England about recovery and packages of care and the usual, for CHC, so we need to make sure there's sufficient funding for CHC.
So in terms of the hospital discharge programme, the only additional risk I would say there is if the ask from the whole of Cheshire and Mersey exceeds the HDP pot, which is held at the Cheshire and Mersey level. That is the point at which the 913 would be at risk. So if we didn't receive the full 10.4 million.
Okay, but at the moment, your understanding in terms of our current financial position, it's not at risk, therefore we can support this.
Yeah, so we should get that money, and the 275,000 is within our H1 plan.
Lovely. Thank you very much. Any further questions? And for clarity, I wasn't suggesting there was disagreement in there. I came across wrong, Claire. I was trying to suggest that there was a different in the presentation to governing bodies to what we might agree. And that clearly has been driven by the fact that it's been done at very short notice and you've not had opportunity to discuss it as a team. So I think all we can do really is go ahead with the original ask and agree what our original asks are, which are on page 89 of your pack, which is to, I won't read them out. You've all had opportunity to read them. We are asked to agree the shortfall, approve the ongoing funding for the primary care hot hubs, agree to scale back the designated setting but keep it on retainer, and to note and endorse the next steps and proposals. Are we all content to do that? Tracy?
Yes, I am. Don't worry, I'm not going to be disruptive. Completely support everything, really wholesome discussion. Just for point of clarity, I probably didn't make this clear. What I'm talking about is that we put in place some staff from the continuing healthcare team earlier in the year to support the hospital discharge team, and I don't want us to lose the opportunity to do that again. So it's not just the general CHC stuff, it's about that. So if we can just use that phraseology in the minutes, that will help me be clear what the point I'm trying to make, which we can pick up outside the meeting. So thank you.
Okay. Thank you. So I've seen no further comments, so I think we're in agreement with that. It takes us to item 4.4, which is 4.4 on page 102 of your pack, which is the prescribing team. As we've previously discussed, I and GP colleagues are conflicted, and so I'm handing over to Wendy. Our apologies for handing over late, Wendy.
Okay, thank you. Wendy Williams, Deputy Lay Chair. As Andy has said, obviously GPs in this part of the meeting are conflicted, although we have had a great deal of input previously to this, and while I welcome some comments from them, should they be required today, they will not take part in the approval or agreement at the end of this. I'm going to hand over to Tracy, and Tracy was going to take us through the points.
Thank you, Chair. So yeah, I should have introduced myself earlier on. I'm Tracy Cole, Director of Strategy and Partnerships. I'm going to give you a quick overview of the Cheshire General Practice Prescribing Scheme for 21-22. And I'd like to welcome Mark Dickinson, who has joined, so that he can help with some of the technical questions later on if we have them. So firstly, thanks to a wide range of colleagues, particularly in the medicine strategy and optimisation team. Janet Kenyon in particular deserves a mention. She has been the author and a main driver of this paper. She can't be here today to present it, otherwise she certainly would have been here. So what I just want to describe to you is within the paper that it offers 4 options. I'm just going to talk you through briefly what they are and then major on option 2, which is the recommended option, and explain why I think we should agree this today as a governing body. So first of all, prescribing schemes are not new in Cheshire, but this is the second year that we're proposing a single Cheshire scheme. And you'll see in response to one of the questions raised at execs, we've included in there a summary of what other CCGs in Cheshire and Merseyside are proposing, so that you can be assured that we're not stepping outside of a way of working that others are looking towards, that could then be adopted and enhanced as part of an ICS in future. So the scheme proposes 4 options. Number 1 is no scheme, and as I go through these, I'll kind of knock off why they should be discounted, if you will. Not having a scheme would destabilise existing posts, which are in people who are employed currently, and I think would present a missed opportunity. So I hope we can park option 1. Option 2 is the recommended option, and I'm just going to talk to you a little bit more about that in a moment. Option 3 is continue with the existing scheme, and you'll see from the text within the paper that this is no longer appropriate due to information that's now required within the DES, the enhanced service, so that is not an appropriate option. And number 4, the option was really that you know, give people the opportunity to suggest amendments to the proposals and enhance and change what's in there. And we haven't received any major suggested changes, and therefore, with the very wide engagement that's taken place, we are recommending option 2. So just whilst I touch on engagement, just to be clear, it has been through both East and West membership. It's been to the Strategic Commissioning Committee, it's been to execs and the GP prescribing leads. And very importantly, Cheshire LMC, Local Medical Committee, have been asked for their views on it and have given them at some of those meetings. They're formally going to respond to us in the next couple of days. So I think we can, we have had an indication that they will be supporting a scheme and helping with this, with support for this. If anything does come from that is a counter indication to the recommendation, then I would propose that ideally we agree here and that we make any minor adjustments in agreement with the Cheshire LMC and use execs to carry that through so that we don't delay. So that's just to mop that up. But all areas have endorsed or certainly said that they feel that this should progress through so that governing body can make a decision. So just very briefly then, what is in option 2? 3 main elements. Number 1 is engagement, which is not new, and that is the way that we, you know, it's always part of that. And there's suggested payment to incentivise that to practice, and that then helps us to maintain the contact and use the teams to link in with practices and continue to move on different areas that would then help us using Optimise RX and other aspects. The second aspect is very much the cost saving, the traditional quit element. So that is still in there, and there are key elements within that and requirements for our practices to take place that would deliver some cost savings. But the third element is the bit that I think is really the most important for me personally, and that's about quality. And that would then allow us to look at 3 areas: quality of prescribing across Cheshire, cardiovascular prescribing, diabetes prescribing, and respiratory. I've left respiratory to the end because this is, I think, would set us apart from others from what we understand in terms of considering how we prescribe a lower carbon inhaler across Cheshire, which would then fit with climate change strategic objective. And I think if we do that, we believe that we'll be one of the first CCGs that's looked at this, and then it would put us in the higher quartile in England and potentially the UK for thinking responsibly about how we use our strategic commissioning might. And so I think that's something that's exciting and that we should be encouraging to use the prescribing scheme to do that. So we're wanting to get it signed off today so that it could launch in quarter 2 from the 1st of July. That in itself does present a cost pressure, and you'll see within there that that's detailed because we will miss the first quarter of the year. But I hope you'll agree with me, it's appropriate to start to discuss this with practices earlier, given the pressures that everybody has been under due to COVID. So I will halt there. That tries to give you the overview. I'm recommending that we agree to option 2, but I'm sure you have some questions and we can then talk those through. So thank you, Chair.
Okay, thanks, Tracy. I've got Suzanne and then Pam. Suzanne?
Thank you. Yeah, just a comment. It was interesting to hear all the committees that the paper has been to, but it hasn't been to the Finance Committee. And one of the things that's been flagged at the Finance Committee when we're looking at the H1 is that the only way we can create efficiencies or savings under our control as CCG is either prescribing or CHC. So it's very interesting because we know there's a huge risk also within prescribing because the uplift was a lot lower than we had budgeted for originally, which means there's already a pressure in the system for prescribing. I haven't got the figure in front of me now, but I know it's over 1 million, it might be 5 million. Can't remember, one's CHC and one's prescribing. So I just think we need to be aware. I actually support the scheme, just to make that clear. I do support the scheme. But by doing so, we are creating a greater risk in the fact that we won't be able to deliver our efficiency savings that we're now being tasked to deliver, which are about 4 million. So just as an observational comment on that. Thank you.
Thanks, Suzanne. I've got a comment to just come back on that, and Mark may have as well. I suppose If I'm being really honest, my ideal would be with presenting a paper on programme budgets with prescribing within that, and that we looked at how we potentially increase our prescribing costs but reduce the incidence of illness and health burden by prescribing well, because otherwise we're tactically commissioning and looking for quips that reduce the spend on prescribing, but we might be missing out on opportunities to reduce the health burden and so I suppose I think we are, and that's what we did propose in our commissioning intentions in last year, but we are in a different place in what we are enabled to do at the moment. So I suppose I would think that we should be, this scheme will deliver quality enhancements. It is proposing some QIP, but I also think that there are other areas that we can look under that guidance, which is about slippage of schemes and some of the other things that I think we have talked about in early discussions. Apologies it didn't come through the Finance Committee. I suppose my thoughts were that, and I think that's, I checked with others around this, that it should go through one subcommittee, not more than one of governing body. If it went through the wrong one, you know, I suppose that's part of the discussion really. But
no, sorry, Tracy, I wasn't implying it's gone through the wrong one. I just smiled as it went through a lot of committees, but it didn't, you know, it's just at the time we're looking at the budget. At the same time, we're looking at what we can manipulate to create efficiency savings. And then I read a paper that says how tight the pressures are in prescribing. And I agree, the focus needs to be on the quality, but it's just so the governing body are aware that when Linda, don't take the words out, Linda, I can't see Linda's mouth, but you know, when Linda does the presentation, that's one of the areas we would be looking at as an option to try and create savings. So it's just to, you know, to marry up the picture of what it is at the moment.
Thank you, understood.
Thanks, Suzanne. Pam?
I'm going to watch my GP colleagues' faces closely now. I just am intrigued that we're going to pay the prescribing leads to meet when we haven't done in one part of the organisation, but we're now going to. So do we have to, is my challenge.
Pam, if I can just reply to that, I think the prescribing leads have always been recompensed for their time to attend prescribing leads. It's just been in different pots of money in different funds. So those in Eastern Cheshire have been within the Caring Together contract. There was an element that was to support attendance at meetings, but it wasn't. It was within a global payment rather than something that you had to claim individually.
I suppose my challenge is it not just business as usual? Sorry.
And if I can come back, Andrew, on that, and I suppose Mark, so are we therefore taking it out of the Caring Together contract? So we're not double paying?
I think the Caring Together contract is being discussed wider, and it will be an issue when we have those conversations. That
well, it will be for next year, but not for this year. So I think we have to make sure we're not double paying.
Yeah, well, we'll.
The first review is going to go for next year, so I think we just need to make sure that by doing things once, we're not double paying.
Yes. I'll work with Neil in terms of trying to make sure that happens. It's difficult to be clear what value was assigned to meeting with prescribing leads and having prescribing leads meetings within the contract. But I think we can, Neil and I'm sure could work out a way of ensuring there isn't a double payment, because that would be unfair.
This year, please. Thank you.
This year, yeah, this year.
Thanks for that. Peter's actually put a comment in saying, accepting that we need to make tweaks, the financial envelope cannot be increased as a question. And Linda has had difficulties with her sound. So I don't know whether you still have, you're okay. Do you want to come back on that at all, Linda?
I'm not sure what I'm coming back on at the moment. Sorry, okay. I missed quite a bit of that discussion.
Okay, it was actually to see whether or not the financial envelope could be increased.
No. No, there isn't, no.
A quick and easy answer, Pete. There we are.
Yep.
Okay, Andy, you want to comment?
Thanks, Wendy. I think there's something that's not quite within the paper, but that Tracy certainly alluded to, is concentrating on the quality aspect of this. You know, my conflicts aside, I think one of the things that I'm looking for and actually going to bring up in the next paper, if you don't mind, Andy, is actually resource allocation and how you evaluate investment in different areas, public health areas, and where you get your best bang for your bucks. And actually, the University of York did a study on this just a couple of years ago. And actually, where you get your best bang for your bucks, the second most is coronary heart disease, and the fourth most is prevention of diabetes. So we're actually managing to maximize the population health benefit and also reduction in health inequalities. So it actually ties into another of the things that we hold dear to us on this governing body. So it's not quite being brought out within the paper, but I think it's a hugely important thing that we need to consider as well, some of the added benefits to population health and health inequalities.
A really good point, Andy. I think it's great to see if we can triangulate all the activities into our major strategic objectives. Thank you. Claire, you wanted to come in.
I do, and apologies, I referred to Andy when I was asking my question about finance. Apologies, Wendy. So just in terms of the paper, very happy to support in terms of all the sort of environmental aspects, and I guess Andy McCave's point just then in terms of I guess inequalities, and as you referred to the next paper in terms of differentially investing and prioritising. But I do think we need to go into this with our eyes open, with the additional. We are open, you know, we are supporting this knowing there's a financial pressure, and that's not normally what we do with our prescribing schemes. We normally look at it as a saving. So whilst I support it, I do think we need to, as a governing body, be absolutely clear that we're supporting it and there's a financial pressure. And I would just want us to consider in terms of Q1, how we feel about the fact that we've missed Q1, so what we feel about the engagement costs in Q1.
Comments on that, Tracy? Do you want to come back at this point at all?
Yeah, I mean, I think these are projections, aren't there? So I think we've put in, being clear that there is a limited ability to deliver on the cost improvement programme because of the timing within the year, and I think it needs careful monitoring, and I think that's part of the plan to do that. I think we've just got to be careful about how we find the sweet spot of doing what is reasonable in terms of primary care capacity, and making sure that we commission for quality, not cost improvements all the time. So I suppose this is a different prescribing scheme, but we're in different times, and I think that this sets the way out for us to try and make sure that we look at longer term quality impact and therefore longer term cost improvements, not just in-year cost savings. And I think we may have fallen into that place where we've relied upon our prescribing budgets for those quick quips, and I think it's time for us to think longer term, and then perhaps that doesn't come out in this paper, but it is really important that we think about those areas. And so I'm really grateful to Dr. McCallaby for bringing those in, that this is where we can have an impact about the well-being and the health inequalities for those conditions that do adversely impact on areas of deprivation in Cheshire more. So perhaps that doesn't come out in the paper enough, but I think that's probably something that we should be you know, looking to do, rather than just very quick in-year quips via this budget.
Thank you, Tracy. If there are no other questions at all, or challenges or thoughts, given those ideas that Tracy has just outlined, which are that this is a broader issue that we should consider, and given that we have had approval via each of the stages that this paper has been through, we're being asked now to consider the options, and I think we did, and approve those proposals, given the proviso that there is a cost pressure, given the LMS is also, we're waiting for comments for those to put some additional thoughts to it, and given that this is needing to be monitored throughout the year, the projections of this will be monitored. Are we happy to approve the proposals? Yes? Okay, then they have been approved given the provisos. Thank you, Tracy. I'll hand you back to you, Andy.
Thank you all.
Thank you very much, Wendy. That takes us to our next item, which is item 4.6, which is the health inequalities on page 119 of your packs. So I'm handing over to Claire for this. So Claire, would you like to introduce this for us, please?
Yeah, thank you. So I'm going to introduce it, that's okay, whiz through some very high level points, but because there's so much information in the paper, and thank you to Amanda Ridge, Associate Director of Strategy and Partnerships, for holding the pen or the typewriter on this. Typewriter, that's very old fashioned, isn't it? You know, the keyboard, gosh, on this, but thank you to Amanda. So I'm just going to, if that's okay with colleagues, whiz through it, but then I'm going to hand over to Gwydion, to Chris and to Leslie as our governing body health inequalities champions, if they'd like to sort of take the conversation further. So I think really the key point in the paper is item 6, what more can be done. So we have brought this paper today as an health inequalities update on the back of a paper that came in December last year and the governing body development session in May. Governing body members have asked us to come back and basically, you know, inform the governing body what we're doing around health inequalities in terms of supporting the population. So I think the key point here is 1.2. Health inequalities are complex and can't be addressed by the NHS alone, and that's reiterated throughout the paper, and I know Gwydion, Chris and Leslie will repeat that as well. So the first section I want to take you to is really 1.12. So you've got some really good helpful context and background, but 1.12 is really about Cheshire. Talks about here in terms of, I guess we are viewed to have very good health in general. That hides and sort of averages out some real inequalities, and you can see there in 1.14 the areas with highest levels of inequalities are Ellesmere Port, Blake and Winsford, North, Crewe and South Macclesfield, and there's information attached to the document from our BI team in terms of some of the data packs, which gives you information on those inequalities. You can see again in 1.15 in terms of the impact that health and clinical services has on health inequalities. I think what we need to do, but unfortunately both Directors of Public Health aren't here, but this is about a single approach across place, and it's about integrated prioritisation, funding and delivery. I'm going to take you to 2.3, if that's okay, in terms of what we've done recently. So it's recently what we've done in terms of the CCG, in terms of setting up our health inequalities subgroup, but we have been playing into this and working with our partners for as long as, you know, sort of CCG and predecessor organisations have existed. I guess that's just repeating the message about this is not CCG's responsibility on its own. So we have worked with our local authorities, and Gwydion and sits on Cheshire East, Increasing Qualities Commission, and then Chris and Leslie sit on the Poverty Truth Commission in Cheshire West. So we've got real engagement at that strategic level across the partnership. See in 2.8 the actions taken by Cheshire CCG, and there is an enormous long list of activities and actions that the CCG is taking part in, leading, commissioning across all of these marmot areas. And I think they're really helpfully listed there for you all to see just how involved the CCG is and all the fantastic work that is going on through our commissioners, through our clinicians working in partnership. I think 2.26 is important just to remind you all in terms of the EQIAs that go on in terms of our investments and our commissioning. And then you go on to the next section, which in terms of being a partner, as we've discussed in the informal meeting, but in all the work we do, we are the integrated care system. So when we sign up to something and when the ICS signs up to something, we're taking part and we're responsible for that. You can see in section 3, I think the first sentence is really important there in terms of reaching out to those people who've lived with lived experience is imperative. understand the best way to tackle health inequalities, and we're doing that. There's really, really good evidence here, particularly some really recent evidence in terms of the COVID vaccine campaign. But you can see all the details there. I'm not going to go into it in detail, but Jonathan presented last month about the microsite in terms of involving people and communities. So I think there's really good evidence about what we're doing. So I'm going to come on to the sort of, I suppose, the slightly maybe depressing section now in terms of limitations. Andy helpfully mentioned it in the previous item, as did Tracy, in terms of our 2021 commissioning contracting intentions and the ambition there in terms of investing in the third sector and health inequalities, reducing investment, zero growth in our secondary care contracts, and then COVID hit us. So all our ambitions for this agenda have been halted to a certain extent. So we have to work within those limitations, but we have continued to prioritise place monies and invested over on nearly £2.5 million in our 2 ICPs. So they have invested in local priorities, local health inequalities priorities. But I think the limitations are that currently the flexibility we have to move in via budgets within the NHS. I think the challenge will be, as we move forward into place governance, using BCF, IBCF, using opportunities through discretionary spend for all providers and all partners. You know, where do we want to invest? You can see in section 5 loads of brilliant work that the BI team do with our public health teams in terms of the data packs, and you can see the information, and there are data packs for our primary care networks and our care communities to look at the population and make their own decisions in terms of how they prioritise on that. So section 6, what more can be done? Absolutely loads, of course. And I guess the challenge is to the governing body, really, about what's our risk appetite, how do we want to move this going forward, what flexibilities do we have this financial year and going forward, and setting, you know, a marker in the sand for the ICS as Cheshire moves into the ICS 21-22 in terms of differential investment, prioritisation. We are challenged by our local authority colleagues, but we do this together. We had a single approach to budgeting, a single approach to commissioning prioritisation, and a single budget. We'd get much more bang for our bucks. So that's in terms of what more could be done, and I know colleagues will want to talk about that. I'm going to stop there, Andy, and bring others in if that's okay. I just wanted to whiz through the paper because there's absolutely loads in here, but that was just very, very high level. So if I can invite Gwyd, Chris and Leslie in the first place, please. But I think really 6 and 7 are the key sections of the paper. Thank you.
That's absolutely great. For colleagues to come in, I'll just remind you of the time, because we do want some time for questions and discussion on this as well. So go ahead, folks.
If I could come in very briefly, Andrew. Thank you, Claire, Gwydon Rees, Governing Body GP. So Amanda Ridge has put a lot of work into this paper, and I think we can all accept that this is complex and we want to do better. I suppose what we need to do is we need to come together and we need to work out what levers we can pull, because I think the issue of differentiated budgets is the essential marker that we can potentially put down, because that's never really been done, and we do have to be realistic and we have to ask what's deliverable. And I don't really want to say more than that. I just want to give Chris and Leslie the opportunity to come in and then hopefully have a good discussion about it. Thanks.
Thank you, Chris and Leslie.
Chris, do you want me to go first?
Yeah, if you go first.
Okay, that's fine. I suppose I'll try not to repeat what's already been mentioned. It's a huge piece of work, and a lot of great work's already started, which is really positive. I think, just to reiterate, I think we've got a real opportunity with perhaps the changes that are going to be taking place, that we'll be working more on a place basis, hopefully working more towards working together with partners. And I think it's key that we work with the local authority to offer a holistic approach to addressing inequalities, because a lot of it is based around You know, not just health. Health is impacted by sort of housing, financial difficulties. So there's a lot to consider. But just to say, there's a huge amount of work already ongoing, and we have huge ambitions to try and improve this further.
Chris, do you want to comment?
I completely agree. I think we often talk about health inequalities, and there are so many wider determinants that it's almost life inequalities, and that we can't medicalise that. And there are so many opportunities for the CCG, the NHS, working at place to really make a difference, you know, real targeted. But, you know, people without safe, secure, suitable housing, without a living income, you know, access to a healthy diet and green spaces, education and training, over 50 years of their life will become unwell sooner. And I think, you know, it was our council colleagues that talked about people need hope and opportunity. And, you know, there isn't a pill for that. So we're part of the solution, but we need to, I think, look wider than the usual partners.
Thank you very much. Thank you to everybody who's presented on that. Before we go to a more open discussion, I think the really important part of this, I mean, I think we've discussed this before as a governing body. We know the background. I think we agree with the aims and objectives. So what perhaps you should focus on is the section 6, which is what more can be done, and perhaps clarifying a little bit what the ask is. Clearly, we're saying we need to do this at place, we need to do this with partners, and that's taken outside of our direct decision making into a collective decision making. Is that what we're asking for? Or I wonder whether there's something else which is in there, which is, I think perhaps Claire hinted at, perhaps Gwyd hinted at, which is, are we asking, saying to the governing body, well, what is your appetite for spending what is health funding on things which you might call public health? What is your appetite for differentiating funding between areas based on health inequality, which we haven't done before? And so perhaps that's where the discussion should be. And then how do we firm something up to actually have a decision on what those things are? Because there's nothing in front of us today which is we can say yes or no on a decision. It's direction of travel stuff, isn't it? So I think that's where perhaps the debate should be. So I'll open it up now for wider debate. Andy?
Thanks, Andy. Thank you for everybody who's actually getting involved in this. I'm hugely interested myself. My question really is something that Claire mentioned, and it's bang for your bucks. So I can actually look at, you know, whether it should be a health or whether it should be social care or whatever. I think we need to work that out as a system, and there will have to be some investments in that. But actually, having articulated from all the BI data, this is where we are in Cheshire. It's a very, you know, it's a rich county that has got lots of different health inequalities. So where on earth do you start? And there has been work on this, and certainly the University of York has done some studies on this just a couple of years ago, and they can give you, they've looked at all the public health interventions that were reported through NICE up until October 2016, and they've basically put values of cost effectiveness on each of these things, including maximum population net health benefit and reduction in health inequality and potentially saving money. And the top thing, far and away, as an investment on this was investing in domestic violence and abuse. That's not really been, so we've looked at different things that we could do in Cheshire, but that happens in Cheshire too. And so I'd question whether we've looked at this whole list and whether we are actually getting, as Claire says, our bang for our bucks. Number 2 is coronary heart disease. And number 3 is type 2 diabetes prevention. Then you get smoking reduction. And then you get into things like reducing absenteeism, you know, with, again, something that we need to play into with our local authority partners. So there's a list of things. There's of the 130 things they looked at, only 18 maximized population health benefits, reduced health inequalities, and actually were potentially saving money. So it's probably worth taking a much more analytical view, perhaps, and actually seeing about whether we are actually investing our money in the most appropriate places.
Thank you, Andy. To save everybody asking you, I'm sure colleagues would be interested in that reference, and if you would distribute it to colleagues, I'm sure that would be appreciated. Any other questions or comments? Dan.
Hi, Dan Howcroft, secondary care doctor. I mean, I think we probably all agree that we've all talked about the left shift of spend and all the rest of it, and public health and all these things, try and support where we can. The challenge is always going to be, as always, with a set amount of money, how do we do that in a way where we're not having, you know, the problem is all these things are almost unknown people at that point. They don't know they're going to need it. But if you're having to remove a service on somebody who's currently using a user, how do we balance those two things out? Because unless we suddenly get a big splodge of cash, which I think is unlikely anytime soon, to start all these things up, it's just how do we get the balance right? I think we all acknowledge that prevention is better than cure, but we're a cure-based system at the minute. So unless we stop offering cures to certain, I say cures in the loosest possible sense, but treatment to people or particular services, how are we going to do this? And it's that balance, because people feel a loss far more strongly than the potential benefit they get at a population level. And I think that's just it's always the challenge, I think, unless it's pump primed in some way with some finance. That's just my view.
Thank you very much, Dan. Good points. There's almost a sort of a fix me, and we're pretty much a good fix me service. There's help me. We're not so good at helping, so help me live with the problems that I have. And there's to prevent me having a problem in the first place, and we're probably even worse at that. We're very much a fix me service, aren't we? That's part of the difficulty, and we need to shift. So I've got Christine and then Paula and then Peter. So Christine.
Thank you. Chris Morris, independent governing body registered nurse. Pleased to see the comments around the EQIAs. It was a point that was raised in the Quality Safeguarding Performance Committee last time, which you'll see later in the report, that we really feel that EQIAs should be done for all service reconfigurations changes by all partners across the ICS to ensure that health inequalities are fully considered at that point. So just wanted to make that comment.
Thank you very much, Christine. Can I bring in Paula, please?
Thanks, Andy. I just wanted to speak to Andy McCallaby's point about the domestic abuse agenda, and whilst I recognise it might not be in this paper, it's just to let you know that we are part of a piece of work across Cheshire and Merseyside to look at a bid for some additional funding around sexual assault referral services and the domestic abuse agenda. And that would take us nearer to being more closely aligned with some of the recommendations in a toolkit. It's called the Pathfinder Toolkit, which has been discussed at a Quality and Safeguarding and Performance Committee in the last few months, and align ourselves to some of the best practice there. And actually, there was a launch event. It's a fair few number of months ago now, and the CCG was represented. Claire was invited, and we were there on Claire's behalf, around actually some time spent with the police, and trying to make a very clear and obvious response as a collective, as a system to domestic abuse. So based on the evidence base I think that you're quoting, all I can say is that from a domestic abuse perspective, we have invested in domestic abuse services, but I think if you look at the Pathfinder Toolkit and the best practice, there's more to do. And I think it's a real positive as well that we've joined the Cheshire and Merseyside work in terms of putting the bid in.
Thank you very much, Paula. That's good to hear that. Peter, want to come in?
Yeah, Peter Monday, a lay member for governance. I should have identified myself earlier. I'm just sort of going straight to the recommendations, really, and the second bullet point around that, around clarity on the ambition of the governing body. Now, there was a question about appetite. I mean, I have an insatiable appetite for addressing health inequalities, and I think probably just about everybody else does in the governing body. So I think we should, that should be clarity enough. But I would add a rider to that, which picks up some of, I think, Andy's points, is that anything we do differentially should be, by way of an intervention or funding, should be evidence-based. So we don't just channel money into a postcode. We do it on the basis of evidence. But nevertheless, I think we should somehow get into, as part of this decision, record that we have an insatiable appetite.
I think that's a good point to put to everybody. Do we disagree with the fact that we have a big appetite for this? The consequences of decisions based on that are a separate thing, which we haven't quite got before us today. But I think we can say that we do think this is something which is important, and we have an insatiable appetite for. Let's go for a large. Okay. Thank you very much. Oh, Tracy, do you want to be? And so, Tracy, you want to come in? That'll be the last comment, and we'll move on.
Yeah, thank you. I also have that same insatiable appetite, if that's how we're putting it. I just think this is what we all came here to do, isn't it? To long term see improvements in, and I like the life well-being rather than health inequalities, you know, the term that Chris used. I think it's much bigger than fix it and health stuff, isn't it? So I suppose I was just wondering about, so completely support everything in the paper, but section 6 has got some short-term and long-term suggestions in a little blue box, and I'm just wondering whether they should be widened given some of the evidence that's been suggested by Dr. McAlevey, and perhaps our clinical leads and clinical champions on this could help us go back and just check that list is the right list, and whether we then whether something goes through finance committee as to how do we do something differently with our money around this. That would be my ambition. Because the problem is we don't have money, do we? But how do we direct our finances to that? And I'd be completely up for that, and whatever I can do with to support that, that would be my hope and dream, I think.
Okay, I can see that Linda's put her hand up. I am going to take this as the last comment, Linda, and it'll need to be brief, please.
Okay, thank you. It's just, I think for me this is really, really difficult. So it's sort of like we need to know what we're spending the money on now. We need to know what the benefit we're getting from that spending. And then we need to know which services we're going to stop and how we're going to stop them and over what time frames. Because are we doing things that we're really efficient at but aren't really helpful to be done? How do we identify those? Because it's only when you move the services that you move the money. You don't move the money and then move this, because the service is still there to be paid for. So it's identifying, you know, how you get the best outcome and the biggest benefit, and then disinvesting to reinvest. And we never talk about disinvesting. This here says all about improving, investing, but actually if we've got a fixed sum of money, we need to say what is it we don't want to do because it's not helpful and not producing really good outcomes. So what are we doing to disinvest so we can reinvest in the right things and therefore improve outcomes? So it's about the service, not just about the money.
Absolutely. And I think Dan and Gwydion might mention values-based healthcare at this point. And we've got Dan's problem ring in our ears as well, which is all our money is presently spent, and there are people using the services that we spend the services on. So it is a very difficult problem. So let's move on. Let's look at our recommendations on this. So we're asked to note the information contained in the paper, which we can do, provide a clarity on our ambition, which I believe that we have done. I think we probably can add here that it'd be great to see this probably amended and come back. Agree to work via the place basis on this, which I think absolutely we are in agreement to do. Probably what we need to do is a bit of a jiggling act, isn't it? A bit of chicken and egg stuff. In those discussions that will happen at place may well have an ask of us as a governing body about how we may wish to invest and not invest. We have limited flexibility about how we do that at present, as we understand. We always have had because of the financial pressures, but even more so at present. But I think that needs to be a two-way conversation, isn't it, about what might we be able to offer to place, what are our flexibilities that we can offer, and what do the two places with us in attendance want to do about taking some of these agendas forward. So my ask would be that this would be a bit of a watching brief for us. Could we have an update of what's happening at that point? That's the last suggestion, is that we agree a quarterly update and progress from the Strategic Commissioning Committee on this. So the next thing is to note the agreement that the group's oversight and approach to health inequalities becomes part of the remit of the Strategic Commissioning Committee, and that then we then ask for a quarterly update from the Strategic Commissioning Committee on this. So is everybody in agreement with those actions that we're asked to present? Lovely. Thank you very much. That then takes us to, so thank you very much for that presentation. We could have spent a lot longer on that, but we just don't have the time, I'm afraid. So thank you very much. It was very interesting and very important. So let's go on to item 5.1 on page 154 of your pack. And I think Tracy's going to introduce this, and then Richard's coming in, and we have guests. I think will join us. Guests are appearing as we speak, so welcome to our guests. I'll ask people to introduce themselves as you first speak, if that's okay. So if I can hand over to Tracy, please, for this item.
It will be a very brief handover, as I'm welcoming a warm welcome to colleagues. And the format for this will be that Richard Burgess is going to present a short number of slides for the CCG, and then we've got Sheena, Suzanne and Nush to present some slides from Cheshire and Wirral Partnership, so that we can look at both sides of what we're doing to make sure we cover off what we need to do for the very, very important topic around mental health for Cheshire population. I think this has come because we want to be really clear how we're spending our money, how are we getting the best for that population, and particularly in view of the greater pressure that all of our population are enduring because of the impact of COVID and mental health. So I don't want to take any more time. I'm sure Richard and others will introduce themselves as they speak, so that we can take that topic through. So over to Richard.
Afternoon, everybody. So I'm just going to briefly cover some slides. Is someone able to share, put the slides up on the screen? Hopefully they'll come up. Technological disasters today. So I'm briefly going to give an update following on behalf of the Strategic Commissioning Committee. We had a recent deep dive in May on the Mental Health Investment Standard and Long-Term Plan. So what I intend to do is just briefly recap that discussion and then hand over to our colleagues in Cheshire and Wirral Partnership, who will talk a bit more in detail in terms of some of the challenges, some of the initiatives going ahead this year. So there is a brief report in your packs on page 154 as well, which just covers the session from Strategic Commissioning Committee in a little bit more detail and captures some of the discussion elements that we had, as we did put some considerable time aside to discuss this. So I'm mindful we only have a much shorter amount of time today. So next slide, please. So I aim to just briefly recap where we're up to, what will be achieved, what are we currently spending, some of the expectations and our priorities, and then I'll try and spend a little bit more time on some of the key challenges. So next slide, please. So this slide just briefly covers off what we've achieved. So how far have we come in terms of since the Mental Health Investment Standard was introduced. And just a couple of points we really want to dwell on. That, you know, access to services has increased considerably, and there's a couple of figures. There's data starting to flow much more now. Since around 2017, we're getting much clearer data around mental health services. We never really previously had that, especially from a commissioning perspective. So we're seeing, you know, greater access in terms of perinatal and children and young people services. I do want to mention, though, even though we're meeting our adult IAP, so improving access to psychological therapies, waiting time standards, that it does not reflect the growing pressures in primary care, and this is some of the discussions from the committee that we got into. There is a challenge around access for IAP, which we'll talk a bit more about later, and it's kind of a demand and capacity challenge there. So yes, we're fine on those waiting standards, but there's not enough people going into that service that we really need to get going, because they'll then stretch those waiting time standards. So I'll touch on workforce a little bit later as well. Next slide, please. So this next slide just briefly shows a breakdown of where we're spending our money. So currently, this is where we're spending our money on against the mental health categories. As you can see, Cheshire and Wirral Partnership are our main provider of services, and thus I'll hand over to them shortly. There's a subcategory there just in terms of complex care spend, because it's a considerable amount of money. So this is more in terms of individual care packages that we commission. So next slide, please. So just to briefly explain around what is, the mental health investment standard and the long-term plan, and I appreciate a number of you were at this deep dive. So just to kind of reiterate, the mental health investment standard is based against our core allocation. So this isn't the entire pot of money that we invest and spend against mental health. This is our recurrent allocation. We do also have available to us 2 non-recurrent pots this year, so the Service Development Fund and the Spending Review money. This is non-recurrent funding. Next slide, please. So against the mental health investment standard, which is measured and categorised, again, it doesn't capture everything we spend. For example, learning disabilities, dementia services are excluded from this target, so to speak. But additional things are included, such as prescribing costs and continuing care. So there's a categorisation, if you like, around mental health investment standard. But something else we're working towards is the long-term plan for mental health. And this has different categorisations. So there starts to be a bit of a drift and misalignment, which we'll talk about in a little bit more detail in a minute. But the table at the bottom just summarises what we're spending against the mental health investment standard this year. And those categories we just broke it down to are roughly our long-term plan categories, as opposed to the much more complex mental health investment standard categories. We feel it just simplifies our work areas a little bit, showing you where those investments are being made this year. Next slide, please. So as I mentioned, the long-term plan ambitions and a long-term plan ambitions tool, and what this table in the middle is basically demonstrating is what the ambitions tool is telling us we should invest against these category areas to meet the outcomes of the long-term plan. And you can see it varies from year to year considerably, with this year being 2.7, just under 2.7 million. So as you can see from the mental health investment standard, where we're investing over £4.5 million, and the long-term plan ambition is saying we only need to invest £2.7 million this year, there's a bit of a disparity there, and it changes year on year in terms of what we're trying to achieve. And there's a little bit of an emerging gap we're trying to understand in greater detail at the moment, because how these targets have been calculated were based on legacy investments. So in terms of the outcomes being achieved, we need to understand, okay, we need to, what the overarching outcomes we're trying to achieve is additional access to services, for example. We need to understand if our baseline was from a lower starting position than other areas in the country, then just by meeting the mental health investment standard every year, which we have done and the legacy CCGs have done also, we still have a huge challenge in terms of meeting our long-term plan ambition outcomes and targets. Next slide, please. This is just a brief summary of what was expected at a national level with the long-term plan ambition. So you can see where some of those numbers come from. When we talk about, for example, adult common, for example, where you've got your IAP service in there, it's talking about maintaining standards, but there was increasing access nationally to 1.9 million adults by 2024. This has then now been broken down to many sub-targets that we're working to on an annual basis. But within that overlay, as you're familiar with, is our oversight framework, so what we're held accountable against. And we are working towards the long-term plan, which has, for example, an IAP standard of 25%, although the oversight framework hasn't been updated and has an exit standard of 19%. Next slide, please. So this is just a summary of those additional non-recurrent investments that are being made or are currently in discussion around those investments being made. So a lot of the non-recurrent service development and spending review pots are coordinated regionally at an ICS level. And planning is just in the round on these sums of money at the moment. There is a mental health oversight group within Cheshire and Merseyside, and there's some planning processes going around in June that are due back, I believe tomorrow, in fact. So the additional details around deployment of these investments will come through the CCG's governance, so we'll be informing Strategic Commissioning Committee further on these once further clarity is gained around these specific areas. It's interesting, it's worthwhile mentioning is that these additional non-recurrent investments have to be met recurrently, typically the following year by the CCG. So one kind of informs the following year's mental health investment standard. So again, I'll touch on it and some of the challenges around this kind of misalignment and our ability to target some of our investments against the national direction. Next slide, please. So this slide you would have seen previously in our priorities document when we went through the whole CCG priority program, which was presented to governing body. Well, this just highlights where those investments against those category areas are. And in terms of detailed plans, so this is aligned against the NHS planning guidance on our commission and contracting intentions, that's what the numbers mean to the right. Detailed plans, again, we're going through our planning processes due at the end of June, which will come through the new programme delivery group, onward through strategic commissioning committee, and then assurance will be given to the governing body around detailed plans of how these investments are being deployed throughout the year and what outcomes they're achieving. Next slide, please. So just some the challenges really. So that's an overview of what the mental health investment standard is, the long-term plan. As I keep mentioning, there's a bit of a growing gap. So as we've understood this, there's this emerging gap between the mental health investment standard and long-term planning ambition. And we know in Cheshire, looking at national benchmarks, proportionately against our entire allocation, we do spend a lower amount on mental health services. We need to understand this, so it's not that cut and dry and that simple. So we are undertaking further work to understand what this gap is and what it means in terms of delivering against the ambition. It's also worth mentioning in terms of kind of chasing these investments in direction for the long-term plan, and this captures some of the discussion we had at the committee. It takes us a little bit away from focusing on local population need. We are the national direction is informing kind of investments against established services, established targets, and it takes a lot of this investment up. So it's worthwhile to mention that kind of misalignment, and we need to really get to grips on how we can start to influence that, how we can start to potentially move money that's already been committed around within our providers. And we talk about this in a lot of the integrated care partnership work we've been working through in the last year. So I just want to touch on performance and contract management. Obviously, given the current mandated light touch regime we're operating in with providers, but it came through quite clear from the committee. There are, let's be honest, there are inherent inefficiencies in our existing services that we do need to work on. It's not all about new investment, even though this is what I'm talking about. Again, I need the governing body to understand that it's assured we're meeting the mental health investment standard. There is a considerable work to do in ensuring that existing services and pathways are performing and that they are more closely integrated into primary care, as there is a huge growing pressure on primary care's doorstep, especially, it was there before the pandemic and it's just exacerbated the issue. So finally, touching on workforce as well, there is a huge workforce requirement, especially to grow the access agenda. This is becoming really apparent through the work we're doing on IAPT at the moment, where we've got to really step up on access, get more, another direct referral service, which will take pressure away from primary care. But we have a huge training program to undertake to get those access standards up to meet the 25% target against our prevalence and population. There's attrition to plan against there. It's an ongoing challenge. There is a Cheshire Mersey piece of work being coordinated at the moment so that we're addressing this from a system-wide perspective, so that we're not just focusing on individual providers to address the training and workforce need, that we're much more coordinated on this at a system. It's also worth mentioning, again, coming back to the local need and local services, because of these standards, because of these targets, previously developed counselling services or community mental health support services, they didn't count towards the IAPT targets. There were many local counselling initiatives which primary care services, or even now through the linked workers and social prescribing, so that stuff doesn't contribute towards the targets, but it has huge impacts into our population. So there's a bit of a misalignment there we need to kind of focus on work on as well. Next slide, please. So just wrapping up my section really. So what we wanted to assure the governing body on through the strategic commissioning committee is that we are planning to meet the mental health investment standard, which is a requirement of the oversight framework, and that we're planning to over-invest against our long-term plan ambitions tool. So the mental health investment standard is asking us to invest just over £4.5 million. The ambitions tool is a much lower calculation. So we are going to plan to over-invest against those targets. But really to note that we need to do much more work on understanding this misalignment, the historic and legacy gap of investment, and that we're going to bring back further detailed work around the deployment of investments and assurances of outcomes of what our investments are going to deliver on. So that's just summarising my piece. And what I'd like to do is hand over straight to colleagues in Cheshire Rural Partnership now, who will present on the work and initiatives that they're leading on, and then we'll have a section for questions towards the end. So I'll hand over.
Okay, good afternoon, everybody. I think we hopefully got a presentation being coming up. So whilst that comes up, just to introduce myself, I'm Sheena Comiskey and I'm Chief Executive of Cheshire Rural Partnership. And it's a great pleasure to be able to present to you this afternoon. I think it's really interesting and great that this item comes after the item on inequalities, because as I'm sure you're all aware, probably some of the greatest inequalities in society are for those people that are suffered by people with learning disabilities and mental health needs. So it's great to be able to focus as the next item on this today with you all. So as I said, I'm Sheena Comiskey and I'm Chief Executive of the Trust, and I've got two colleagues to support me here today who are Nushta Sanathan, Dr. Nushta Sanathan, who's one of our two medical directors, and also Suzanne Edwards, who's our Director of Operations. So next slide, please. So we are Team CWP, and we are the main providers of mental health services in Cheshire, but improving the outcomes and the lives of people with mental health needs is absolutely a partnership piece of work right across a large number of partners in Cheshire, and that of course includes, most importantly, the citizens of Cheshire. So actually looking at how we improve people's mental health is clearly something that we all need to work on together in partnership to do that. So in terms of Team CWP, we do provide, as I said, the mental health and care services for local people, but we also provide learning disabilities, community physical health in Cheshire West, and all age disability services in the rural area. And we also have 3 GP surgeries. We are very proud that we're rated good overall by the CQC and outstanding for care. And that's something that we've consistently achieved over the whole of the rating period by CQC. We employ about 4,000 staff and work over a multitude of sites, 60 in total, but also a lot into people's homes, and the population covers about 1 million people, but we also have some very highly specialist services that we provide for a much larger population across Cheshire and Merseyside, and in some cases beyond that. About 65,000 people access our services last year, and we're really proud of the fact, in partnership with yourselves, that we were winner of the National Mental Health Service Redesign Initiative for the Value Awards for working to improve specialist mental health services for local people. So that's a great piece of partnership work that we did with you. So that's something that I know that we're all really proud of. So I'm going to hand you over now to Suzanne Edwards, who's going to take you through the next part of the presentation. So thank you, everybody.
Thank you, Sheena. Can I have the next slide, please? So my name's Suzanne Edwards. I'm the Director of Operations, and my pronouns are her, hers and she. So over the next 10 minutes or so, we're going to go through 5 elements covering the delivery during COVID, and I think that's just about setting the scene in terms of our approach during COVID and how we've been addressing some of the challenges faced. Then around transformation, looking at how the spending review monies, the service development funding has been planned and the proposals that are sitting behind then, followed by the new models of care and an exploration really of the challenges being faced and some of the opportunities though that are available to us, and what quick wins we might want to take forward. So can I have the next slide, please? So for the following 6 slides, these have been taken from the national benchmarking data. So we've been submitting data on a monthly basis, which has actually been tracking and mapping in terms of some of our activity and performance throughout COVID. So when you see the slides, you'll see COVO 18, that's COVO 18, that's CWP. And just to make people aware, this is trust-wide data, so this also covers activity within Wirral as well. However, I just wanted to emphasise some main points before we move on to this, is really to celebrate that we've been able to continue to provide core services. We've been able to continue to provide face-to-face appointments, home visits, and also as well as enhancing and embracing, the new digital technologies that came along with the pandemic. This was all being underpinned by a clinical prioritisation framework. And like all NHS providers, there has been time when we have had to divert resources to areas of greater need to ensure that we've been able to continue to provide safe care. So, for example, within our inpatient units. Next slide, please. So looking at our community mental health services, so since the start of the pandemic, referrals accepted into our mental health teams have been above national average. And although during the first lockdown we saw a dip in referrals into services, we're now seeing levels that are going beyond pre-COVID activity. Next slide, please. This looks at our bed occupancy for adults, and you can see here that frequently our adult inpatient units have been operating at 100% occupancy. This provides very little flex to respond to increased demand, and this has been further compounded by ward closures due to outbreaks, staff absences, longer lengths of stay, and also high acuity within our inpatient units. So as a consequence of this, we've had to reconfigure wards, we've introduced surge beds, we've accessed mutual aid across Cheshire and Mersey, as well as accessing beds in the independent sector. However, I would like to stress that despite this increase in demand, our figures for out-of-area placements also remain low against the national trend. Next slide, please. So just considering the previous slide, despite the high occupancy for adult acute care for our admissions per 100,000 registered population, they remain consistently lower than the national position, and that's also reflected in our lower bed base compared to other mental health providers. Next slide, please. However, as you see on this, and this is for older adult admissions, the trend is reversed here. Next slide, please. And this just looks at our child and adolescent mental health services. And so despite some of the historic investment challenges, our team caseloads remain consistently higher than the national position. And we are now seeing a month-on-month increase in referrals being made into the service. Next slide, please. And then just looking at our bed occupancy, this is our Tier 4 provision. We can see here that bed occupancy has fluctuated, and this probably tracking the impact of the third lockdown on children and young people's mental health. Next slide, please. So the next 5 slides that I'm going to go through set out the transformation planned and proposed for this year, utilising a combination of the service development funding, referred to as SDF, spending review funding, and then some of the deferred income. And I know that that was a point that Claire had asked that we cover within this presentation. So plans have been drawn up with CCG colleagues, and it's important to note that as well as funding existing and new provision within CWP, it's also been utilised to commission services from voluntary community and social enterprise organisations. Next slide, please. So this slide sets out the delivery plan for children and young people. So you'll see a significant proportion of this is directed to further developing and sustaining the crisis response for children and young people, including the 24/7 crisis line and the initial phase of the implementation of the Cheshire and Mersey agreed crisis response team. And that's looking at a hub and spoke model across Cheshire and Wirral. You'll also see there as well, in terms of planning around the 18 to 25 pathway. We know that this causes real challenges and can be really disruptive as children transition into adult services. So this is very much under development and looking at how we support people with autism and complex needs through that transition process. And can I just highlight on this slide, the liaison funding for the Countess and Macclesfield actually sits under the adult delivery plan, so apologies for that. So next slide, please. So with regards to the adult services, again, we see the continuation of the discharge schemes to support flow, earlier discharge and reduced lengths of stay. And that's utilising funding both within CWP, but also utilising voluntary community and social enterprise organisations. So looking at some of the crisis beds that we've been able to commission, also some of the step down and some of the wider support around debt as well. We see a continuation of the crisis line funding, but also an enhancement of crisis interventions for adults. And then we've got the IAP funding as well, which links into the Cheshire and Mersey work that Richard has already referenced. And then again, another scheme that's under development is around dementia. This is around supporting the waiting list for people requiring assessment, but also including post-diagnostic support and the introduction of Admiral nurses who work alongside families and other care providers. And as I've said, this work stream is currently under development. Next slide, please. So this slide looks at the deferred income delivery plan and it sets out the spending and the proposals around this, and it covers 4 main areas. So one of them is around the support for patients with severe mental illness to receive their COVID vaccination. Again, we've been looking at utilising voluntary community and social enterprise organisations, for example, working alongside Pathways and Healthbox. We've got monies around the children and young people, and this has been split into 3 parts. We've got a third of that going into the third sector to support access targets. We've got another third of that around about the enhancement of the neurodevelopmental offer and increasing capacity within primary care, and we'll be looking to working alongside primary care and colleagues around developing that shared care agreement. And then there's a third of that going in to increase the establishments within core community services for CAMS. There's also funding for the mental health in school teams, which has been really successful, especially during lockdown, and we've had some really positive feedback from that. And then there's the ongoing funding for the crisis line, and people, if not aware, that was set up at the start of the pandemic. Next slide, please. The next 2 slides, I just wanted to demonstrate some of the services and the resources that are available for children and young people, some of which have been developed during the pandemic, but demonstrate the range of offers aside from the mainstream specialised CAMS provision. And again, just drawing your attention to the development around the mental health support teams. This has played a real significant role and will continue to do so in terms of being able to offer brief interventions, support the whole school approach, but also offer advice to staff and other agencies, and particularly important to keep young people in education. And then finally, if next slide, please. We've got the 24/7 urgent crisis line, which again was set up at the beginning of the pandemic. But what we're also seeing next month is the launch of Shout across Cheshire and Mersey, and this will be a text message service that again people can access if feeling anxious or stressed. So I'm going to hand over to Nush now, so thank you.
Hello, my name's Anushka Sivananthan. I'm one of the medical directors at CWP. So if I can just move us on to the next slide, please. Thank you. So I want to just talk a little bit about the future as well, and the importance of co-producing it with people who access our services, but also yourselves as commissioners. So next slide, please. So some of the things that we've delivered this year is, as part of the community transformation funding, is about the expansion of provision of services for people with a personality disorder. So these are people with complex psychological needs for whom there was no specialist service. So we've been able to enhance these services, and currently we're in recruitment. We're further developing our eating disorder services, not the specialist end, but actually for preventative services. So working with BEAT, who is an eating disorders charity, to be able to get early intervention, early support to those with eating disorders. And just to let you know that the greatest rise in demands on our services are for those with eating disorders, both children and adults. We've enhanced our community pharmacists by having pharmacists within our community mental health teams who are able to then support people with complex needs and complex medication regimes. And we're just developing our mental health intensive support services. So these are people with long-term mental health needs who need intensive support in the community so they can fulfill their lives. Next slide, please. A number of you will have seen me working with PCNs regarding the additional role schemes within general practice. And again, this is on our radar, including looking at our workforce planning about how we jointly develop and deliver these posts. Next slide, please. So I'm not sure if any of you have seen this diagram before. This is from Cheshire and Merseyside, and actually talks about the whole range of mental health needs and where the roles of specialist services can be helpful, but where the role of other groups of staff and other assets are available. And I think, I mean, I did hear Chris talking about housing and the importance of people having money and food, and these are basic needs which impact on people's mental health needs. So I think it's just for your information really about the plurality of responses that are needed for people with mental health needs, not just about and the role of specialist services and inpatient services, but actually there's a whole range of needs that can be met through other ways. Next slide, please. So in terms of specialist services, and our future ambition is the importance of how we as specialist services integrate and wrap around primary care networks. So how we use our existing resources as part of the multidisciplinary teams that work around populations. And this kind of gives you a visual way of showing how that will happen. So instead of having a split between primary and secondary care, that actually secondary care are part of the community and part of community services that are there for populations. Next slide, please. Thanks. So what will be different to how it is now? So first of all, mental health workers will be part of your care communities or our care communities, all ages. We'll be moving from a referral system to request for help, and that includes the wider community care team. Can I just say this isn't just about a traditional doctor to service referral. As Suzanne said, we're able to commission third sector support, and we need to link them in with community assets that already exist, including PCN social prescribers. We're developing the roles of paid peer support workers. There's a lot of great evidence that having peer support actually improves people's mental health and well-being. It's not just about the clinical delivery of care. And the other thing is about supporting people to access physical health care and physical health care checks. And again, you touched on health inequalities for the population. Next slide, please. So what are we going to do? So we're working at the moment with PCN clinical directors and PCNs. We are looking at how we integrate our older people's mental health, apologies for the abbreviations, OPMH, across all our PCNs, and working with our consultants to offer multidisciplinary team meetings virtually to PCNs to be able to discuss complex cases. Suzanne's touched on the other things that we're doing in terms of peer support and the importance of working much more closely in commissioning voluntary community sector support. And we're also doing this, and I think it's really important to mention, when we've talked about existing services, well, there were gaps in our existing services, so we need to understand about how we're going to fill those gaps, mainly for therapeutic supports, so psychology, OT, and other psychological therapies. So that is part of this work that we're going to be doing this year. Next slide, please. So we do have some challenges. I think, you know, Richard was really open and transparent about some of the historic challenges. You will all be aware of the consultation we did in the old Central and East patch, so we could invest more in the community. We have got a low bed base and low community investment, so our ability to switch from inpatient to community is fairly limited in what we can do. We do have significant workforce shortages, so just as an example, the expansion of consultant numbers that happened in other specialities did not happen in psychiatry. So we had probably less than 10% of expansion in our consultant numbers compared to other specialities. And checking with our director of nursing, the plan is to recruit, and this is nationally, we didn't have local figures, an extra 50,000 mental health nurses. That's the gaps we're talking about in terms of workforce. So we've got an opportunity to think creatively, but in our terms of our clinical workforce, we've got some significant challenges. We've noticed over the years there have been reductions in voluntary and community support, and that's sometimes been commissioning decisions, and that's not just about yourselves as commissioners, could I just say, but also the pandemic has meant that a lot of these support structures are virtual and some and aren't in real life, so that has had an impact on people's mental health. And I was delighted to hear the bit about health inequalities and the work you want to do, because currently there is a lack of system-wide mental health prevention and a strategy to deal with that. The talks about domestic violence, early intervention in childhood, adverse childhood experiences, all of these things contribute to mental illness, but they also contribute to physical health illness. So we've got an opportunity to do things very different. One of our other challenges with our footprint is that we've got 30 PCNs we work with across Cheshire and Wirral, and they have different populations with different needs. And clearly the need to reduce existing health inequalities. So just for information, apologies if you know this, so 3 times as many people with a learning disability have died than people without a learning disability, you know, and they're dying in their 30s and 40s. If you are from a ethnic minority background and have a learning disability, you're 3 times again more likely to die from COVID. So this is the range of health inequalities we've got to tackle together. And next slide, please. However, we do have some opportunities. So the first kind of ones are some quick wins we could do. So to support we know there's a massive pressure on general practice. We can look at setting up quick email advice. So again, early access to specialist help virtually. We can look at how we improve clinical relationships. And I think I do know a number of the GPs on here with whom I've worked clinically. So actually improving our relationships helps us manage risks, help us with helping patients more effectively. There is something about simplifying care pathways, and we know where commissioning has been fragmented, and commissioning separately from local authority and health has sometimes led to fragmentation. So we've got an opportunity to streamline some of that. Clearly, the care communities development, particularly community assets, the importance of local authority, will also help us in improving the mental health and well-being of our staff and our population. So that's, you know, those are really good quick wins. some of which we're on with, some of which we can do, and most importantly, and I think touching on what Sheena said, is doing this in partnership. This isn't one organisation or one sector doing it, but it's how we work together. So the last slide is just to say thank you, and any questions?
Thank you very much for all those who presented, and so we'll open it to questions or comments. Fiona.
Hi, thanks. So Fiona McGregor Smith, I'm one of the GPs in Northwich, and I know quite a few of you, and I was able to speak to Suzanne actually earlier this week, and she should probably think I'm back on having another old grizzle. But thank you very much. It was very helpful, and I think it highlights to us as the governing body how difficult this whole situation is. So, and as I say, I spoke to Suzanne and another of your colleagues about trying to sort things out at the sort of mild to moderate level, and thank you very much that we're going to try and work together to try and do something at that level, because that, from a general practice point of view, that is our complete and utter nightmare. Trying to manage that and just retaining all the available options. And one of the problems we have is because there's so many bits of voluntary or third sector or whatever, you never quite know what to do with it. So that's something that we are going to try and work on. A couple of concerns I had just from your presentation there. You showed us the referral acceptance rate slides. That was right at the beginning, which showed that we had a very high, acceptance rate of referrals. Do you think that maybe reflects the fact that actually what you're getting referred needs to be seen, and that actually we're better referrers rather than the people who are only accepting 80% of referrals? Does that mean that we're already screening out the people that we are trying desperately not to send on? So if you're having to accept virtually on 100% of referrals, that strikes me as a sort of there's not much room for manoeuvre there, and that was then reflected in the bed occupancy, and that concerns me enormously. We've been there before with non-mental health provision, but if your bed occupancy is 100%, there is no give in the system. There's no leeway for the people who actually need the bed, and there's absolutely no respite for the people who are trying to provide the care. And so that worries me a lot. And I'm saying this as a governing body person, that I think we need to be mindful of that, because then where do those people go? What do we do with them? And how on earth do you, and I think that might be a reflection on when you were talking about the workforce availability. I was wondering whether that is a particular problem locally. Is it because nobody wants to live here, or it's because the work here is too difficult, or is it because when you're actually here, a bit like social workers we hear as well, there's just, the work is too draining, and so the only way people can protect themselves is to actually give up that job and go and do something else. I got lots of other questions, but those were my immediate thoughts just about how really scary this all is and whether we've actually got a sufficient handle on this.
Okay, so thank you for those questions, Fiona. We're going to ask Nush to come and answer them, but just to say, just as an overview, because I do have a Cheshire Mersey role and a national role on mental health, that what we're experiencing in terms of the pressure on beds is exactly mirrored across the whole of the country, and that's to do with the acuity and of people presenting. So that's, the bed position is not unique to Cheshire Merseyside. We also, from a workforce point of view, actually have a very high, compare very favourably with a very high retention rate. But that's not to say that, like all workers or all people within the NHS and care sector at the moment, it is incredibly challenging for people. And we are, as others are really focusing on the well-being of our people. So I'm going to hand you over to Nush to answer some more specific questions, but thank you so much for those questions, Fiona. So just to answer the first one about the referrals and the referral acceptance, Fiona. So actually we're very lucky in Cheshire to have good referrals. So yes, we do have good referrals from general practice. However, I guess part of it is that we have a culture of high acceptance because we know that people have needs. and we might not be always the best place to do that, but we accept them to do the assessment, and we sometimes have to signpost on. So it's not that everybody who's accepted goes into treatment, but we absolutely understand the need for help, and we also understand, you know, as you said quite rightly, there's a plethora of stuff, and it's how do you navigate some of that when you've got somebody in front of you, and what's the right option. So sometimes we absolutely help in part of that. So that's really important. The bit about bed occupancy, mental health services have run hot like this nationally for years. So just to be really clear, so I know it's probably a surprise to you guys. It's not a surprise to us at all. And part of the challenge is having a defined budget, for want of a better term, a defined income. You know, we have to choose how we spend our money, and we have chosen to spend proportionately more in the community because we know we can help more people than in beds, which then means when there's a sudden surge, our bed demand gets quite tight, which is a challenge, but it is managed. And I guess the other bit is that we're able to now provide other options. So, for example, we never used to have crisis houses till 18 months ago. We never used to have crisis cafes till 12 months ago. So we now have other options. So whilst our beds are running hot, you know, we are getting people through flowing through our system. But yes, it is something we monitor. It's something our board monitors, and something we clearly keep an eye on. And I think Sheena's touched on the workforce bit, because actually our retention rates are extremely high. And when we've had our Get It Right first time visits, they always commend us on how low our turnover is. So I hope that's every question answered, Fiona. And you could always email me if there's stuff that I haven't answered. Apologies.
Thank you very much. Are there other questions? Okay, so Leslie.
Hi, thanks for those presentations. And it's lovely to see all the hard work that's going into mental health at the moment. That's brilliant. I suppose my question is related to sort of children and sort of young adults. And I think I've mentioned this before in previous meetings, that and you've mentioned in the paper really that we sort of hinted at the fact that there was probably a bigger gap in the offer for children and their mental health than adults, and sort of waiting times and access. Just anecdotally, that we do get referrals bounced back from PAMs without seeing or speaking to the children or their parents, recommending, you know, websites for treating anxiety, and actually often those things have already been done, and families are reaching their end of the tether really, and we're asking for help. So I suppose it's just, I know how to think about things differently, because I think you mentioned the fact that we need to get to mental health early, and that we need to provide that support early on. So it's making sure that we do look at those, and I think you have done a lot, you know, within the schools and things, but it's not always equivocal across the patch. There's not always the same offer in each school or opportunity, and long waiting times sometimes to see people even in the school. And I just wondered about thinking about whether there is a way of kind of having a single point of access, a single point of contact for mental health. It's very, you know, we talk about having a directory of services for general practice, but if you think about how many offers there are from the tertiary sector, from your perspective in mental health, that's one specialty. We have, you know, tertiary sector opportunities in all specialities, and it's nigh on impossible to know what's out there really, and actually it'd be useful to have somewhere that we can direct people to then direct them on. So yeah, I suppose they're mostly comments really, but just a plea, and I think a lot of the work is happening, just as making sure that we do bring those sort of reduce those gaps if possible. Thanks.
Yeah. Really, again, really appreciate that question, Leslie. Suzanne, do you want to come in there?
Yes, thank you. And I think this just reflects the conversation I'd had with Fiona earlier this week in terms of how do you navigate all that support that's available to children, young people and families, and knowing which one to go for and how do you access that. And I think one of the things that we'd agreed is actually how can we pull that all together? So actually you've got that information in terms of the different options, because there are different options because there's choice as well for people, and it's about making sure that that's easily accessible and easily understood, and then also providing some of that guidance around, well, actually, you know, what is appropriate for specialist CAMHS provision, and where else can I seek that support. And I think just picking up as well on the mental health teams in schools, I think this is really going to be key going forward. You know, children spend a lot of time in school, and if we can help increase the skills and that support that's going into schools, that will help in terms of that early intervention and prevention. Alongside that, I think it's also important that we've got the 24/7 crisis line that both parents, carers and young children and others can actually utilise to get that help over that 24/7 period.
Lovely. Thank you very much. Thank you very much for your responses. I haven't got anybody else asking anything at the minute, so I'm going to put in a very brief 2 pence worth, if I may. I'm just reflecting on where we might have wanted to be had the world gone as we wanted it to be. Largely, there not been a COVID-19 pandemic, and had we been able to continue with our ambition to be a strategic commissioner, and thinking what that means for the next step we have now of there being an ICS and provider collaboratives, etc. And I said, where would we want it to be? And I think we would at this point have been discussing, well, what is the population need for in terms of mental health? Where's the stratification? Where are those needs being met? Where is the added value? And unfortunately, we are still talking about access targets and funding as our drivers and our understanding of the system and how we're providing care. So it's just, I don't think I can perhaps you will respond to it briefly, but it's just, where do we go next with this? How do we, as CCG becomes ICS and we have provider collaboratives, how we move into that way of thinking in terms of outcomes and population health, and rather than the way that we are still thinking and talking, which is in terms of access targets and funding. So I will pause just in case you want to respond to that, but you don't need to. It's just a pondering of mine.
I'll, if I may, and Andy, just to respond to that, we are absolutely focused on population health needs and actually coming together to respond to population health needs, and working as an integral part of the 2 ICPs in Cheshire West and East, and responding to need in that very different way. And clearly, you know, when you've got a lot of investment coming into mental health services, which, you know, we'd all see as very positive, clearly people want to see at this point some of the old ways that things got measured, which is access targets, etc. But it's both, because it's actually about how we're making a difference to population health, reducing inequalities, and how we do that in an integrated fashion across all partners and with the people of Cheshire. So thank you. Yeah, Bob on there. Thanks, Andrew.
Lovely. In which case, oh, Chris, I'm surprised you hadn't commented, Chris. I thought your hand would have gone up earlier, but Chris.
Well, I think that's just testament to the quality of the presentation. I had a few questions, but they've already been answered. And I think, you know, so it's just reflections. I think it's fantastic to see you adopting the PRISM, and knowing how that's worked in Cambridge and Peterborough. I really look forward to that here. And, you know, something close to my heart is peer support workers. So that you're rolling that out is brilliant. So, you know, thank you.
We can take your smiles as responses. Claire.
Thank you. I guess firstly, thank you to everyone who's come along. Richard, on behalf of CCG, Sheena, Nush and Suzanne, so thank you for coming. I think it's really important that we do this, and I think it's helpful to do it a bit more actually in terms of, you know, getting the whole system to present. But I think really helpful presentations. I guess there's a multitude of conversations behind all this, isn't there, in terms of money, metrics, performance, etc. But I think Andrew's point's right, and I know this is dear to, and I know this is dear to the hearts of CWP as well as it is to the CCG in terms of that more strategic, outcome-focused, value-based work. So I think it only, it's about how we work together, doesn't it? At that Cheshire and Merseyside level, we're all partners. We've had this conversation earlier. We are all partners in the future ICS, and we all have a part to play. But we also have a part to play to advocate for the population of Cheshire. And I think it's how we can do that together. Make sure we sort of we have to get our priorities right and have a single priority for Cheshire around this, and in terms of how we invest and what the outcomes are. But I do think by working together, and I guess Sheena chairing the Cheshire and Mersey group, and I know Tracy's getting more involved in that now, which is great, and it is that clinical leadership as well. So we need our clinical leads front and centre to be with NUSH, having these conversations with our wider partners on the outcomes, absolutely on the outcomes, and as Sheena said, and that's why we did the sequencing of the agenda items. In terms of inequalities, we know that health is only a tiny part of inequalities, so it's so important that all the points we discussed in the previous agenda item are wrapped up in this sort of mental health agenda. So just a few comments, but I think having this approach where we have a sort of the commissioning discussion and the provider discussion, great. I think going forward, it'd be nice to have a single presentation and a single discussion. Thank you.
Thank you very much. I think that just leaves me to reiterate the thanks to all of our presenters, and particularly to our guests for coming along and sparing the time to present to us, and it's been warmly appreciated by the governing body. So thank you for that. Thank you for your time. Thank you. Take care. Right, colleagues, that takes us on to item 5.1. We are a bit behind time, I'm afraid. On page 159 of your pack, it's the report of the committee chairs. I'm aware that there are, and I'll go to the committee chairs for comment if they wish. You don't need to comment if you don't wish, but I'm aware that there are some things we particularly need to note, which is there is a revised terms of reference in the Quality, Safeguarding and Quality Committee, and there is a decision ratification of the CTG to adopt the pay protection policy from the Remuneration Committee. So I will pause and just go through our chairs in sequence. So Suzanne, do you want to comment anything on?
No comment, Chair, thanks. Take questions.
Peter? We'll come to questions at the end. No. Pam?
No, I've got no comments to make. I'll take questions if people want to ask me them.
Did you want to comment on the Rumination Committee bit?
Well, yeah, it explains it quite well in the paper. We actually bought a proposed pay protection policy back to governing body, but we were asked by the governing body to go away and do some more work on it. But when we actually looked at what our proposal was, we were actually at odds, which we knew, with the rest of Cheshire and Mersey. So what we decided to do, given that events have now overtaken us, is to recommend to governing body that we actually do approve the pay protection policy that is common to most of Cheshire and Mersey already.
Thank you. We'll come back to that as a decision. Christine.
Thank you. Neil, had he been here, was going to update just a few bullet points on the performance issues to the governing body, which I have here in his absence. So I'm happy to share this if we've got time to do that now, or to share it later.
We are a bit short time, but if you could share it now.
Okay, it's just an update on some of the performance points which you felt is really important for governing body members to hear. So we've already heard from Jackie about the significant pressures on the urgent care system, including hospitals, primary care, mental health sectors, and those are in excess of pre-COVID limits. And that impact is acting detrimentally on some of the performance metrics, particularly around the A&E standards. And so this work is being reviewed through the A&E delivery boards, and mitigating actions are being put in place. So it's important that we note that. Elective care recovery plans continue to make progress, with increased numbers of patients being treated and reduction in the numbers of patients waiting over 52 weeks, which clearly has been of concern to us. There's been some delays, Neil says, in confirming processes associated with the elective recovery fund, and this has impacted on the volumes of patients who are being able to be transferred to independent sector capacity. So we'll watch that space on that. A process to clinically prioritise those patients awaiting diagnostic tests have been communicated and has started in June. And this is similar to those processes already in place for the surgical waiting list. So we've discussed that here previously. We was keen that we talked about diagnostic waits being addressed. Risks associated with elective waits are being reviewed, in particular relation to the Countess of Chester and also their implementation of the electronic patient record. And we considered those risks in the committee and have asked for some further work on that. The committee was updated on the work to address reported long waits across some mental health services, and you have heard some of that in our previous presentations, and we're looking for some validation on waiting list numbers at the next meeting. And finally, the committee looked at the revisions to the general practice standard operating protocol, which emphasises face-to-face access to appointments in general practice, and some additional assurance was offered in relation to how this is working in practice, and the general practice dashboard will be coming to us in the future, looking at a range of metrics to address variation and work at practice level. So those were Neil's points really to supplement the report that you've had in front of you today.
Thank you, Christine. Did you want to say anything about the revision to terms of reference? Do you think that's covered in your report? We need to.
No, that's covered in the report. It's really just to include the elements of performance oversight that previously sat with Strategic Commissioning Committee, have been incorporated in quality safeguarding and now performance.
Thank you. Wendy?
No, I've got nothing to report. It was all on today's agenda.
Lovely, thank you. In which case I'll open for questions, and then we'll go to our the decisions that we have. So any questions for any of the chairs or executives regarding the committee reports? Tracy.
I'd just like to commend the work that's included under climate change. I think it stands us in real good stead as to what we need to achieve on that agenda. So if you just could note thanks to all the hard work that's gone into that. It's really good that it's there, and it needs to keep going through Strategic Commissioning Committee. So we can just note as is requested, but I just wanted to draw special attention to that, because we've got a lot of staff working on that as a voluntary piece that they're doing because they have passion and belief in that agenda, as well as it being something that they are necessarily part of their job description. So just if we could note that, and thanks to Sophie Lamb, Bernadette Bailey and all our climate change activists. Thank you.
Thank you for that, Tracy, in particular. It's good to hear. Right, if there are, Claire.
Sorry, were you, so I support Tracy, what Tracy said, and thanks to everybody. Were you asking for us to agree to the REMCON terms? REMCON paper?
Yeah, going to do that now, yeah.
Sorry.
I need to interrupt you then, because there are conflicts of interest or potential conflicts of interest here.
Yeah, I was going to mention those as well. Yeah. So we do have two members of the governing body, don't we, that potentially are conflicted in that they are employed members of the CCG who have voting rights, which are Claire and Linda.
And also you, Andrew.
I don't. I've checked with Matthew, and it doesn't apply to me, so I don't have a conflict.
That because you've got more than 2 years service.
No, when I checked with Matthew, I should be chairing the item if actually this is the case, but I checked with Matthew when we discussed it previously and was assured that it didn't capture me and therefore I wasn't conflicted.
And I'm not sure it captures me and Linda, because this is this is not our. I'll let Matthew do it, but I don't think it could. Linda and I are conflicted either.
Matthew.
So if you've got an employment contract, it does, but it doesn't materially impact on you because everyone around the table is over 2 years service. So even if we willingly chose to go to a new job tomorrow and went on to the new pay protection policy, it wouldn't materially impact on us. So it's a conflict, but it's possibly the most remotest of conflicts, of interest. So if you've got an employment contract, it's a policy that affects you. But because of the 2 year issue, it's not material, if that makes sense. That's the difference from last time I had a chat with you, Andy. Sorry, I should have probably updated you on that one.
In which case, I think I will ask Pam to discuss the governing body decision around the REMCOM, and I'll be quiet.
Okay, thank you, Andy.
That's okay, Pam.
Well, basically, I'm just going to ask the governing body if they would agree to approve the paper as is put in the appendices. Does anybody disagree? No, so we can agree that as a new policy for Cheshire Clinical Commissioning Group. Back over to you, Andy, now.
Thank you very much. The only other thing we have to make a decision on is the change to the terms of reference of the Quality Safeguarding and Quality Committee. Christine gave us that sort of outline of what those were, and you've all seen them. Is anybody not in agreement with those changes or any comments on those changes? No, thank you. In which case, they'll take those as being agreed. And Tracy has very ably highlighted the climate change work. So thank you for that. So I think, unless I'll just pause in case there's anything else on that item in terms of the committee chairs reports, in which case we'll move forward to the forward panel, which is section 6.1, page 189, and is for noting or comment. Traditionally, Peter has something to say, but no. In which case, I think we are able to close the meeting. I'll thank you for your attention and contributions, and my apologies that we are closing a little later than we planned, but only just 10 minutes or so. So thank you very much, and there is a slight catch-up meeting after this, just as a reminder for those who are able to attend, and we'll see you next time. Take care.
Thank you.